but they can listen. So when you talk about the liver is the largest organ in the body, correct? If you didn't know that, it's the largest organ in the body. And where is the liver located? Right upper quadrant of the abdomen. That's important that you know where that's at, all right? Because when patients come in and have abdominal pain, that's one of the hardest things to try to figure out. What is causing this abdominal pain, okay? Is it gallbladder? Is it liver? Is it pancreas? Is it stomach related? Is it referred pain? I don't know. So it's really hard sometimes to figure out what am I going to do for this person with abdominal pain. The liver is very vascular, okay? The liver receives the majority of its blood supply from the venous system. Not from the hepatic, not from the arterial system, excuse me. So it receives the majority of its blood flow from the venous system, okay? And at any given time, that liver contains over 13 to 15% of your blood at one time. That's a lot of blood for that liver to have, okay? So when you're talking about the liver then, what are some functions of the liver? What are some functions of the liver? And why do I even care if you know some of the functions of the liver? Why is that important? Because it impacts things that are going on in the body. And if you don't know that, then if you don't know what the liver does, then you're not going to understand. This one's going in the trash too. You're not going to understand what's going on in the body. So when you talk about the liver, you need to think about functions, okay? All right, so you need to think about functions of the liver. So the liver has about 500 functions. Remember that from anatomy class? The liver is a very complex organ and it has a lot of different functions. So what's a function of the liver?
Cholesterol.
Okay, cholesterol. So what does it do with cholesterol? Okay, it makes it, right? So it makes cholesterol, and why do I care about cholesterol? Why do I care about cholesterol? What's cholesterol do? Pardon me? Well, yeah, that's important because it blocks arteries. Yeah, that's the cardiac lecture, though. But yeah, it does block arteries, Keisha. All right, so basically what cholesterol is important for is it gives strength to your cells in your body. So it helps strengthen your cells. So if you don't have it, then your cells are going to be weak, more chance for your cells to rupture, all right? So it gives cell strength. The other thing that it's important for is hormones. It plays a vital role in helping to form estrogen and testosterone, all right? We need estrogen and testosterone, don't we? So it helps in the formation of estrogen and testosterone, okay? What else does the liver do? Okay, protein synthesis. Okay. Okay, and also where's cholesterol? What else does it do? It helps with digestion of fats. Okay, so cholesterol is synthesized, okay, by the liver. It goes into the bile acids. And then those bile acids help break down fats in the body. So cholesterol has a lot of different functions, okay? What else does the liver do? Okay, filters, right? So it filters. It clears the blood, doesn't it? So it filters, very important. So it clears the blood of chemicals and toxins and all that kind of stuff that your body doesn't want to have, right? So chemicals, drugs, alcohol. Remember medications, right? Liver is very important in breaking down medications so they're not toxic in the body. So liver also does that. What else does the liver do? Pardon me? Bile. What's bile? It continuously makes bile. What's bile for? Breaks down fat. Good. It breaks down fat. All right. Where is bile stored? Well, a lot of people don't have gallbladders, so now what do we do? Eat less fat. Good suggestion. So what happens? I don't have a gallbladder. So now what do I do because I can't store bile? Do I just not break down fats? Wow. down. You got it. It goes straight to the small intestine. So when you get fat into the small intestine, it just goes right down the bile duct into the small intestine, because the bile duct empties into the small intestine. And so does the pancreatic duct, okay? So it just goes into the small intestine. You don't need a gallbladder. You really do not need a gallbladder. So all it is a storage compartment, which is nice if you have it, but you can also end up with problems with a gallbladder, right? So you really don't need a gallbladder. So basically it just goes right into the small intestine then, and then you can, it breaks down fats. What else does it do? Okay, synthesizes glucose. So it's needed for glucose metabolism. So what does it do?
It stores it as glycogen.
Okay, it stores it as glycogen, and then if your body needs it, it breaks it down into glucose, right? So it converts glycogen to glucose. And we need that sometimes, don't we? All right, especially patients that are sick. All right, hypermetabolic patients where they're burning off a lot of calories and we need some glucose for energy. What else does it do? Oh, ammonia. Good for you. Ammonia. What's ammonia all about? It's not the cleaner. Not talking about what you clean with, and then everybody gets the fumes and then has to go to ER because they don't have the windows open.
Byproduct of protein breakdown?
Okay, byproduct of protein breakdown, right? It's formed where? In the intestinal tract, okay, by the breakdown of bacteria. And normally what happens is it goes to the liver breaks it down, and we can secrete it in the body, correct? And what do we secrete it as? Urea, okay? So it gets converted to urea, which is excreted in the urine. Now, if this doesn't get excreted and it builds up in the body, what does it cause? Hepatic encephalopathy, okay? Or portal systemic encephalopathy. Excellent, good. So ammonia is critical in the body, okay? It's produced by bacteria in the intestines, and it gets broken down into urea and excreted from the body. But think about the patient then that has hepatic problems or liver problems. Now they also have renal problems, right? So now I'm sitting there thinking, okay, where are they at in this spectrum of liver disease? And so now we got to worry about ammonia levels, right, on these patients. So ammonia levels are critical for you to think about. What else does it do? Okay, coagulation factors, right? Coagulation, extremely important. So it's needed for coagulation, okay? Coagulation factors are very important, okay? What do you think this A is? It's not ammonia. What's the other thing the liver's important? Albumin, okay? So albumin. Why do I care about albumin? Yeah, it carries medications, fluid, okay? What do I care about fluids? Keeps the fluids in the pipes, right? Right? The lower the albumin, the more third spacing, right? So it helps keep volume. It keeps that pressure in those blood vessels so stuff stays where it's supposed to, okay? We already talked about bile, right? And we just talked about coagulation factors. Okay, so ABC, so I'm just kind of taking that, and then you have a D, which we talked about, detoxify. Okay, all right, and I put an S for storage, just for me to remember. Well, what does it store? Your glycogen, okay, and then we have metabolism. So the M is metabolism, and what did we say? It breaks things down in your body. The main thing that we're worried about is the ammonia, right? Ammonia, it breaks it down into urea, okay? And that's important for you to know. So albumin, as we talked about, is needed for keeping fluid in the vascular space, and we also know that it helps to transport drugs, right? The other thing that it does is it binds with calcium. Okay, so that calcium can travel around the body, correct? All right.
Can you say that again? What binds with calcium?
The albumin. Albumin binds with calcium so that it can travel around the body and the body's able to use it, okay? Bile, right? We understand bile, correct? Okay. So basically, what is bile made of? Old red blood cells, right? Stuff like that, okay? And then the other thing bile does is it transports cholesterol. So the important thing with bile is it transports cholesterol and helps flush it out in our stool. So it floats around and it picks up that extra cholesterol in the body. It takes that cholesterol so that we excrete it in the stool, okay? Coagulation, what are we looking at? PT, right? INR, right? PT, INR, right? And you can look at your APTT, I guess, in here. So look at all this important stuff already with the liver, all right? And the reason you need to understand that is because if somebody has a liver disease or they're in with liver problems, you got to start thinking about this stuff. Not that, okay, the patient has abdominal pain and they're jaundiced, but then you have to start thinking, what is their ammonia level? Are they starting to have some changes in level of consciousness? If they are, what is their ammonia level, right? Because ammonia crosses the blood-brain barrier, and that's why it causes the hepatic or portal systemic encephalopathy, okay? What is their albumin level? They're starting to third space. Is their albumin level low? If it's low, what do we need to do about it, right? Okay? So we maybe have to give them some IV albumin, maybe increase their protein intake somehow, correct? Do you see what I'm saying? So you got to think about other things. So what are their coag labs? You need to know that, and the reason you need to know it is what if they have to have an invasive procedure done, right? And their labs are to the point where their INR is 6.8. Do you think they're going to do something on that patient? Absolutely not, because that patient's going to bleed. So these are things as the nurse on the floor you got to be thinking about. It's not just going in there and saying, okay, I got a patient with liver disease, great. It's thinking about these kinds of things, okay? They try to give patients that have liver disease, they try to watch how many medications they give them, right? Because the liver's sick and tired and it can't function correctly, so we got to be careful because it breaks down and detoxifies medications. And if we can't get them out of the body, then we have a problem. So is this making sense? Does that make sense? Okay, I don't know if I had any others. Oh yeah, I had another one written down. So what about, and it doesn't really fit in here, but what about vitamin storage? And somebody mentioned vitamin K already. So vitamin storage, one of them, oh, I spelled that wrong, but one of them being vitamin K, right? So vitamin storage is important. I had that one down. Thank you, whoever said that. Okay. So the liver makes prothrombin, which is your vitamin K, right? So prothrombin is vitamin K, and it also makes fibrinogen. So your prothrombin is your vitamin K, okay? So prothrombin is your vitamin K, okay? Then it also makes fibrinogen, which is needed for clotting. I can't spell today, whatever. Okay. Google it. Fibrinogen. I can't spell it today. Isn't that awful? I can't think about it. Okay, so anything else you can think of with the liver? Those are the main ones, I think. Vitamin storage, you've got that one, right? Glucose metabolism, coagulation, bile, all that good stuff. Okay, so then let's just take a second and think about labs, okay? Let's just kind of think a little bit about liver labs in general, all right? Nothing major, just a little bit, okay? So let's kind of look at labs with somebody with liver. So when we're looking at labs, I'm just kind of giving you things related to liver. I would look at albumin, right? I would look at my bilirubin. Now they can break the bilirubin down. They can do a total bilirubin. If the total bilirubin is elevated, they can break it down into direct and indirect bilirubin, okay? So they can break that down if they need to break it down. And then that helps them find out where the problem's at, okay? Is it actually in the liver or is the problem before the liver? Okay, so they can look at bilirubin. We can look at total cholesterol. Okay, we want to look at LDLs, HDLs, PT, PTT, INR. Those are just some of the liver labs we're going to look at. So tell me about my albumin. If you have somebody with liver problems, what would my albumin be? Okay, it's going to be low because the liver isn't doing what? It's not producing or making it, right? So your albumin is going to be low. What's your bilirubin going to be? It's going to be elevated, right? And I'll show you a picture on that in a minute. So your bilirubin's going to be elevated. What's going to happen with your total cholesterol? It's going to be elevated. Why is it going to be elevated? It's making it, but it's not transporting it to get rid of it in the stool, right? So if my total cholesterol is going to be up, what's my bad cholesterol, my LDL, going to be? It's going to be high, okay? What about my good cholesterol? What would happen to my good cholesterol? Low, okay? My good cholesterol will be low. What will happen to my PT? High. My PTT? High. My INR? High, okay? If you know the functions of the liver, you can know what these labs are supposed to be.
For the albumin, like total protein count, so if the person comes back and has a low albumin and they increase protein in their diet, will that lab then reflect that or no?
That's going to be
not
tough.
working.
It's going to be tough to show a short-term increase with diet,
Okay.
unless it's just a little bit low. The best way to do it is to give them IV albumin, okay? But you can't give them IV albumin when they go home, all right? So eating protein will help some, but it's not going to bring it up like IV albumin would bring it up.
Initially, would eating increase the protein would increase the ammonia level.
Well, it depends. Okay, again, it depends on where the patient is at. Yes, the protein can increase your ammonia level. Hence, the book talks about how much protein the patient should have depending on are they in or getting close to this. And so, in other words, if my ammonia level is greater than 35, which is the top of normal, do you think I'm going to give them a high protein? No, I'm going to give them low to moderate. So again, I've got to look at the patient. Okay, what's the patient picture? Is the patient showing signs and symptoms of encephalopathy? What is their ammonia level doing? Then I've got to base the protein intake on that. Okay, because you got to have some protein. Because if you don't have protein, right, then you know you're gonna lose what? Muscle mass and all kinds of stuff. So you have to have some amount of protein. Okay, so it's all relative to what's going on and where the patient is at. Okay, all right. So when we're talking about the liver, a couple of things that you need to think about. Okay, I'm going to erase this, okay, for all of you is that something else you need to think about with the liver, or you need to understand a little bit about, is what happens with all of this stuff in the liver, okay? So you have a spleen, right? Everybody have a spleen? I hope so. Okay. All right. Everybody has a spleen, right? So what does your spleen do? It does a lot of stuff, right? It's a storage place, and I can't draw well, so.
It makes white blood cells.
Okay, it can make some white blood cells. Okay. So what does it do with our RBCs? Okay, it breaks them down into heme, right? And globin, right? God. Okay, I can't spell that right again. So it breaks it down into heme and globin, okay? I don't need that. So that's what it does with your red blood cells. So it breaks them down into heme and globin, okay? And so that's basically what that does. And then this is actually called indirect. Okay, this is called indirect bilirubin. So when your red blood cells are broken down by the spleen, what happens is that's called indirect bilirubin or unconjugated bilirubin, okay? So basically, you see this a lot when people have like hemolytic anemia, right? And in hemolytic anemia, you get destruction of your red blood cells. So sometimes you'll see an elevated indirect bilirubin in those patients, okay? But basically, this is bound to albumin. So this here is bound to albumin. So indirect bilirubin is a friend of albumin. And so they stay together. The problem with that is it is not water soluble. So I can't get rid of it. Okay, I can't do anything with these dead red blood cells because they're bound to albumin. So if I can't break them down into the water soluble form, I can't excrete them into the bile. Okay, so what has to happen then is that this will go to my liver. Okay, this will go to my liver, right? I don't know how you draw liver. So hello, liver. Okay, that's your liver. Looks a little bit like that, right? It's a little anemic liver. So then what happens is it goes to the liver. When it goes to the liver, it's called direct bilirubin. Direct bilirubin, okay? Or conjugated bilirubin. My gosh, I can't spell today. Isn't that awful? I can't spell today. Or conjugated bilirubin, okay? The conjugated bilirubin is water soluble, okay? So the conjugated bilirubin or direct bilirubin is water soluble. And the reason for that is the liver is able to break it down to a water soluble form, okay? So then what happens is that this gets secreted, okay? So this is your intestinal tract, right? Cute. All right. So it takes that water-soluble form, okay, and then it gets secreted into the large intestine. So this is the intestine. So this gets secreted, okay. So this conjugated or direct bilirubin gets secreted into the intestinal tract, okay. So it gets secreted into the intestinal tract, and then it's converted to something called urobilinogen. Urobilinogen. Okay? So urobilinogen. Okay, it's converted into urobilinogen by the bacterial action in the intestine, because your intestines have bacteria in them, just so you know. Okay, we're all walking around with bacteria inside of us. Make you feel good. All right? So indirect or water soluble gets secreted into the intestinal tract. By the action of bacteria, it gets secreted into what we call urobilinogen, okay? Urobilinogen is what gives your stool its brown color, okay? It's what gives the stool its brown color. However, a very small amount of urobilinogen is excreted in the kidney. Not much, just a little bit. So a small amount is excreted into the kidney, okay? All right? So what happens then, if there's a problem in the liver, this isn't going to happen, is it? So what are we going to have too much of floating around? This, right? Too many of these broken down RBCs, which cause what? Jaundice. Excellent. Which causes jaundice. Okay? So an increase, if there's a problem going on, and that's why sometimes they'll do a total bilirubin, right? Then they'll break it down into an indirect bilirubin and a direct bilirubin, because they want to see where the problem is at. Okay? Is it really a problem over here? Or are we having a problem over here on this side of the equation? So that's what it's going to do. So obstruction of the bile ducts, etc., all kinds of stuff can cause problems related to the liver. So I just kind of wanted to show you all right, how things are broken down. So urobilinogen is what gives your stool the brown color. So think about people, okay, where this is blocked. What's their stool color going to be? Gray or clay color. This is why, okay? Because we got a problem in this system here going on right now in the body. Does that make sense? Okay. I'm going to show you portal circulation a little bit later when we get more into cirrhosis of the liver. All right. So I just kind of wanted to show you that for now and explain to you that's why you need to remember anatomy and physiology. Okay. You can't forget it, because if you forget it, right, then you're not understanding what's going on in the body. All right. We good with that? At least for now? Okay. All right. So let's move on then to hepatitis. Let's start talking a little bit about hepatitis. Some terminology related to hepatitis. I think we just covered it basically here already. So things that I wanted you to think about was ammonia. What is ammonia? What is a normal ammonia level? Why in a patient with liver dysfunction would your ammonia level be elevated? Okay. What is cholesterol? Why is cholesterol important in the body, right? Cell membranes, right? What else did we say? Hormones, your estrogen and your testosterone. What does it carry? What does it carry? I said it carries stuff. No? Okay. Doesn't carry stuff. Okay. Okay.
What were you asking? What carries?
Bile, right? Bile. Okay. All right, prothrombin. What do we need prothrombin for? Blood clotting. All right? Blood clotting. Okay. Filters, correct? Okay. So anyway, I did it a different way because I wanted you to see. All right. Here's some liver enzymes that we have to talk about a little bit before we even get into hepatitis or anything like that. We already mentioned some of these. The ALT is liver specific. So when you see the alanine aminotransferase, ALT, always look at the L means liver, okay? ALT means liver. So that is directly related to liver problems. So when the liver gets damaged, what happens is that it releases this ALT out into the body, and it's an enzyme that's released when the hepatocytes get damaged. So ALT is very liver specific, okay? So you want to think about that. The alkaline phosphatase, or your ALP, is another enzyme for you to think about with somebody with liver disease. The problem with the alkaline phosphatase is it is not just liver, it's not liver specific, okay? Will they look at it? Yes, if somebody has liver disease. It's not liver specific because it can be found in the bone, it can be found in the intestinal tract, disorders of the intestinal tract, etc. But it still is also, you know, secreted by the liver. But it is not liver specific, okay? The AST, or aspartate aminotransferase, is another enzyme that you want to look at in these patients. And basically the problem with this, again, is it's not only found in the liver. It's found in organs that have a high metabolic activity. So you're going to find this in things like the heart, the liver, muscle, all kinds of places, kidney, spleen. So it's found in all kinds of places. So it's not liver specific, but you will see if somebody comes in and they have liver disease, they will do these first three labs. They will do, an ALT, AST, and ALK phos. Then they want to see. And why do you think they're doing all three of them? Yeah, you got to rule out other stuff. You got to rule out other stuff. So you're always doing these labs because we're trying to rule out, is there problems going on somewhere else? Okay. Now I'm not quite sure. The books are a little different, but a normal ALT is usually about 7 to 56 units per liter is how they measure it. That's about a norm. An ALK phos, a norm is about 30 to, Gotta think, was it 110 or 120? 30 to 120, I think, was the normal ALK phos. A normal AST is 10 to 40 units per liter, okay? All right. Then we have bilirubin. Bilirubin is also secreted when the liver isn't working well, okay? So when the liver isn't working well, what's going to happen is we're going to have a problem over here, right? Because this indirect bilirubin, when it comes to the liver, can't be broken down into a soluble form, right? And if I can't break it down into a water-soluble form, what does it do? It stays in the body and it builds up in the body, okay? And then basically what's going to happen, you know, that breakdown of that red blood cells are what your bilirubin is, right? So when you had little kids, remember they always did them little bilirubin things and you stuck them under stuff and they got better. I don't know. My kid, I put him on the end table and turned the light on. I'm serious. It worked. I'm serious. My doctor said that was fine. So we agreed. So anyway, basically what's going to happen is this unconjugated bilirubin builds up in the body, hence the patient becomes jaundice, okay? So bilirubin is something that they also want to draw. PTINR, do I need to talk about PTINRs or are we good with PTINRs? Right? We understand PTINR? Okay. An INR is International Normalized Ratio, and it's kind of used internationally, okay? So it's kind of a standard, all right? And so depending on, you know, where they want the patient is what that INR will be. If the patient has a problem with clotting, they usually like it somewhere between 2 and 3, right? But if they want to go to surgery, they don't want it between 2 and 3 because what's going to happen? The patient's going to bleed. So books vary a little bit, so you've got to look at the labs within your agency. But a normal is about a 0.8 to like a 1.1, 1.2 for an INR, okay? And a normal PT is about 11 to 13.5 seconds, okay? And that's going to vary a little bit, but just to understand what happens when it's high, what happens when it's low. Okay, what's the significance of a high or low related to those labs? Okay, even more labs, serum ammonia. All right, so serum ammonia, remember we said ammonia, well, we didn't say all of this, but ammonia is the end product of protein metabolism. Okay, it's formed when that protein is broken down in the intestinal tract. Okay, so ammonia is formed when the protein is broken down by bacteria in the intestinal tract. And basically what the liver normally does is convert that ammonia to urea. So it gets broken down in the intestinal tract, it floats around the body, goes to the liver says, well, hello, now you're urea, okay? And then we excrete it in the urine. So normally the liver removes that via the portal circulation that we're going to talk about a little bit more when we get to cirrhosis, okay? And so removal from the body is essential because it can affect your brain or your cognitive function. So we got to get rid of it, all right? So basically, as I said, it accomplishes this by turning that ammonia into urea, and urea is excreted by the kidneys, okay? So liver disease, cirrhosis is a liver disease. It's going to be high in hepatic coma, right? Because it's crossed that blood-brain barrier, and now it's affecting my brain. Why would GI hemorrhage cause the serum ammonia level to be elevated? Blood is a protein, excellent. And where's that protein going? GI hemorrhage into my GI system. So then it goes into my intestinal tract and, you know, it can't be broken down, right? So it goes and floats around and the liver can't convert that protein into urea. So anytime protein cannot be converted into urea, right, ammonia builds up in the body. And that's not a good thing because it can affect the cognition or the brain in the patient. Renal disease, we already mentioned, right? If your patient has liver problems and now they also have renal issues, what can I excrete? The urea. I can't even get rid of anything. So it's all going to build up in the body. A normal ammonia level is usually a 35 or less. okay? A normal ammonia level is 35 or less. Why do I have TPN on here? What's in TPN? Protein. Look at the bag, okay? Protein. Now see how I want you to think? Don't sit there and memorize, okay, it's TPN. I can't even memorize. I don't even know what I said because I can't memorize them. I want you to understand it. And what application does that have to this patient, right? So if you know that these kinds of things can elevate that ammonia level and your patient has a problem with any of these or they're on TPN or whatever, then you got to look at your patient, right? You always have to compare the patient. You never make a diagnosis based on just a lab or a diagnostic test, because what do they always start out with, doctors? What do they always start out with? They're looking at history and physical. Excellent. Always a history and physical, even in ER, right? When you look at the ER notes, what happens? Sick 57-year-old patient came into the ER after 2 weeks of, right upper quadrant pain, nausea, and vomiting. You know what I mean? That's what they do. And then they say, oh, based on what they told me, here's my differential diagnosis. So here's the things that I'm thinking it could be. So now let's do some labs and let's do some diagnostic tests to try to figure out which one of those it is. Do you understand what I'm saying? So you always want to compare what you're seeing to what your patient presentation is.
Okay, so last week I went to the doctor with my best friend's dad, who is an alcoholic.
Yep.
All his labs are normal except for his albumin level is low and he is very anemic. He is starting to have pooling in his legs. The red blood cells are breaking down. It's causing discolor and edema.
Well, great. Yep. He's third spacing.
Yep. He's 65 years old. He's been
Yep.
drinking for many years. The
Yep.
doctor said he's fine. Start increasing your protein levels and it'll start coming out. We know he's an alcoholic, but they're not telling him that that's the cause because nothing else is reflective of that. But
That's called probably because here's what happens, and we'll get into that later today, is alcoholic cirrhosis of the liver.
Yeah,
So what happens when you first get alcoholic cirrhosis is you get what we call a fatty liver, which you can see. So that's, they're probably, because he's admitted to having a long-term problem with alcohol, that's probably where he's at. But if he doesn't quit, he can progress. So where he's at, he's stable when you're looking at cirrhosis.
right. So, but the doctors aren't telling him it's because of the alcohol. And that's where I'm getting mad. They're just saying that because you're not eating well and whatever, they're not telling him. So he's like, I'm fine. I just got to start eating better.
And he's not eating better because what's he doing instead of eating?
Drinking.
He's
So
drinking.
They gave him a whole case of Ensures and told him to
Yep.
take 2 of them a day.
Yep.
Got to follow up in 6 weeks. And
Yep.
it's like,
And there you go, because his protein level isn't that low.
right.
It's not low enough to worry about it yet. So they're hoping that Ensure is enough to boost that protein level up to get rid of the edema in the legs. So then that's why there's a follow-up in 6 weeks.
Yeah.
Why they're not telling him it's alcoholic related, that I can't answer.
Yeah, well, because I was there and I
I can't answer that.
And
They don't like to,
he,
yeah, they don't always like to, admit to that.
Because I'm like, well, did you check his PT and INR? And he's like, well, I'm sure we did, and I'm sure they were fine. And like 5 minutes later, he came back and he says, yeah, here they are. See, they're good. And he like got an attitude with me. I'm like, okay, here's a guy that is just in the stages now. So if he starts changing his lifestyle, he probably has a chance. But you're not telling him that. And he was like very rude to me and very mean. And I'm like,
Was he a family physician?
he is.
Yeah, I can't answer why he didn't tell him.
Yeah, that's what I'm like. And
I can't answer that.
And not that he would listen, but I feel like if the doctor would just say, hey, it's the drinking. The
Right,
drinking is why you're
right. And I don't know why he wouldn't tell him that, because he admitted to having that as a problem. So he's probably in like that, he's stable right now because his labs really aren't that bad. But if he continues, then he's going to go from the fatty liver to actual cirrhosis of the
in
liver.
last month, he's lost 10 pounds.
That's significant.
His belly rub and everything are fine, but he's
Yep.
you could tell he's very malnourished. And
Yep.
he's-
And that's what happens with people that drink. They're very malnourished because they drink instead of eat. And then over time, he's going to progress, to having actual cirrhosis of the liver. So it's something he needs to get on right now so we don't get to that point. So, all right, prothrombin, right? It's produced by the liver for blood clotting, right? It's produced by the liver for blood clotting. We remember that? Production is dependent upon vitamin K intake and absorption. And what did we say the liver does with vitamin K? It stores it, right? So that we have to have enough vitamin K to prevent us from bleeding. So prothrombin, again, is produced by the liver, okay, for blood clotting, and it's dependent upon having vitamin K because we need vitamin K for prothrombin to be synthesized, okay? And the vitamin K needs to be absorbed or, right, it doesn't work. So prothrombin. So many factors are really necessary for blood clotting, but that's very basic. So think about liver disease, right? We already talked, right, a little bit about liver disease, correct? And we'll get into it more in a little bit. And so basically, in liver disease, such as cirrhosis. Now, if they have mild liver disease, this PT isn't going to be sky high. Again, you got to put it in perspective of the patient. I'm just giving you concepts, okay? I'm not saying in this patient, and in this patient. That's up to you. I'm just saying in people that have liver problems, liver disease, this can be elevated because what's not being produced? Coagulation factors, vitamin K, right, is not being produced so that these people can have elevated prothrombin time. What about biliary destruction? What's that got to do with anything? What's biliary destruction have to do with anything? I didn't tell you that earlier. Okay, but why would my prothrombin be high in biliary destruction? What did your little notes for your A&P review say? Yeah, probably not going to be able to synthesize your vitamin K. Very good. Okay, bleeding disorders. Do I need to even talk about why it's elevated in bleeding disorders? And fibrinogen, right, is needed for what? Clotting. Okay. And remember, think about drugs. What kind of drugs is this patient on? Is this patient on medications like warfarin or Coumadin, right? Are they on Eliquis? Are they on Pradaxa? Oh, that reminds me. All right, found out something new last Wednesday. Got to tell people, because remember we were talking about cardiac, and one of the concerns about some of the medications was that we don't have reversal agents, correct? For things like Eliquis and Xarelto. Well, we do now. All right. It's been approved by the FDA. I learned this last Wednesday by reading. This is what I tell you guys. You never quit learning. Okay. The minute you quit learning, then you might as well go to McDonald's. All right. Because ANDEXXA. That's the only name I know. Andexa. All right. This is approved by the Food and Drug Administration. My understanding is it's not coming out till 2019 from the article that I read. All right, but that was an article that I read. It was a 2018 article, but I'm not saying that you won't find it someplace already. But now there is a reversal agent for life-threatening bleeding. Okay, they're not just going to give this if it's, you know, whatever. It's got to be life-threatening bleeding. So anyway, Andexa, in case you see it on boards, which you shouldn't, but it's a reversal agent for Eliquis. So, see, learn something new every day, right? Right. Albumin. All right, we know enough about albumin. It's the major protein, right, that's circulating in our blood, correct? So it's that major protein, and it is considered a test of hepatic function because the liver does what with albumin? It makes it, right? It makes it and it secretes it in the blood. And as we already talked about it, it's needed to maintain that pressure in your pipes so that the fluid stays in the pipes and doesn't go someplace else. So if the albumin is low, it's going to cause that fluid to shift from the pipes to the periphery, or with liver disease into the belly, right? Ascites, into the belly. So remember, your peritoneal cavity is a big balloon, and inside that peritoneal cavity are all your organs, okay? And so fluids will shift because that peritoneal cavity is a semi-permeable membrane. And so fluids can shift through that semi-permeable membrane into the peritoneal cavity when the albumin levels are low and lead to ascites in your patients, okay? So basically it can be low in other diseases also. So it isn't necessarily specific to liver, but we have to watch it with liver because the liver synthesizes it, right? So we have to watch it with patients in liver disease. So low albumin levels can be seen in things such as malnutrition, right? We just kind of mentioned that, right? Malnutrition. Burns. Now with burns, which we're going to talk about in a couple of weeks, what you're losing is you're burning the skin. Your skin is a protein. Your muscles are protein. So depending on the degree of burn they have, okay, it's usually 3rd and 4th degree where you see that, they're going to have a low albumin level. Chronic inflammation. What's chronic inflammation do to our body? Okay, it stresses it, but what else does it do? It decreases blood cell formation, okay? Chronic inflammation will decrease blood cell formation. And so the person can become anemic, okay? Starvation, right? So if people, when you're talking about starvation and you're not getting adequate nutrition, right, it lowers everything. So just some things to think about with okay? Diagnostic tests. So whether you have hepatitis or whether you have cirrhosis or whether you have anything related to liver, we need to talk about diagnostic tests. One of them is a liver biopsy, right? If I want to find out what's really going on with this patient, do they have cirrhosis of the liver? Do they have a fatty liver? Do they have anything else? One of the things that I may want to do is what we call a liver biopsy, okay? And what they're doing is doing a biopsy, and then, of course, they'll look at it and figure out, okay, what's actually am I seeing or looking at? So it's a definitive test, which actually is going to tell me, is there some necrosis going on in the liver? Is there scarring or fibrosis going on in the liver? All right. So when a patient has a liver biopsy, what is a priority intervention for you when that patient comes back to the floor?
Bleeding.
Okay. So what's the intervention? Priority intervention. Who said that? Speak up.
Have them lay on their right side.
Yeah, have them lay on the right side, because what am I doing? I'm putting pressure on that liver, right, to try to stop some bleeding. Good, all right? Now, that's not usually the first test they're going to do. You know, they don't go to invasive tests first, right? But I just put it in there because I think it's important. They usually do an ultrasound of the liver first, because an ultrasound is not invasive, correct? And it will still let me know what's the size of the liver. It's going to let me know... look at liver blood flow. Is the blood flowing in the right direction, or are we having that collateral circulation develop because of increased pressure within that portal system? So what's actually going on in that liver? Abdominal x-ray. An abdominal x-ray is very limited, but it's going to tell me, you know, do I have fluid in my tummy? It can tell me, do I have ascites? It can tell me if the liver is enlarged. It can tell me if the spleen is enlarged, right? So sometimes ultrasound is usually done first. If they see abnormalities with that, then they can do further tests like an MRI. So an MRI is always a very good test to do, but sometimes you just can't do it first, right? CTs, right? Liver scans, esophagogastroduodenoscopy, right? EGD. Why would they do that? Why would they do an EGD? Yeah, see if you're bleeding, esophageal varices, right? Because they go in, I can look in my esophagus and see if I have varices. I can look in my stomach and see what's called watermelon striping. You'll see that on reports, and that's because the blood vessels in that stomach are engorged also, and when you go in and look, it looks just like the dark lines, you know, on a watermelon, so it would look like a watermelon. The other thing that I do is I can go down into the duodenum. Okay, I can go down into the duodenum and look and see if there's anything going on in there. But what I'm really looking for is there any irritation or bleeding anywhere in the esophagus, stomach, or small intestine? That's what we're trying to look for. Okay, then we take it a little bit further and we do an endoscopic retrograde cholangiopancreatography. Okay, look at the words. All right, cholangio, gallbladder, pancreas, right? Now remember I said the bile duct and the pancreatic duct empty into the small intestine, correct? Retrograde means to go back up. So when they go down the esophagus into the stomach and they get into the small intestine, you got to turn it, right? Turn the tubing to go up to look in the pancreatic ducts or into the bile ducts. That's why it's called retrograde. It means to go back up, okay? So they can do this test. This is more of an invasive test, right? So conscious sedation, numb the throat, same with the EGD, right? But what they can do with this test is they can look at the pancreas, because they can use contrast medium. They can inject contrast medium through an ERCP, okay? And then it will show if there's any blockages in the biliary system or someplace within the pancreatic system. So they can remove stones, they can put in stents, they can do biopsies, whatever they need to do when they go in there, all right, with an ERCP. The other thing that I don't have on here that they can do is an MRCP. I had somebody who's Andrea's patient had an MRCP. And basically, this is a non-invasive test, okay? So it's a non-invasive imaging test that I am able to look at not only the biliary system, but also the pancreas. So it's looking at the same thing, but it's just non-invasive, okay? So an MRCP, and then your MRI, okay? So those are the tests that you're going to do. So this is just a picture that's showing you the endoscopic retrograde pancreatography. So they put in the scope, they come down, okay, into the duodenum. Here's your biliary system. It's emptying right here, and it's just showing you that. And then here's your pancreatic duct, which is emptying down here. So they can take this tube and go down and then go up into this biliary duct. Maybe they have to stent it. Maybe there's a stone in there that they can remove. Okay, that's the beauty of it. So they can inject a dye if they want, so they can better visualize it if they need to. So they'll determine that when they get in there. So you just take the tube, you go down, you can go up into the biliary duct, or you can go in here and go into the pancreatic duct. So depending on what's going on with the patient, all right? Because sometimes they can get a pancreatitis if they have really bad problem going on in their biliary system, because that empties into the small intestine, right? So if I have a really bad problem going on here, and I have an infection going on somewhere in this biliary system, that bacteria then can go up into the pancreatic duct and cause me to have a pancreatitis. So sometimes you're going to see amylase and lipase drawn to help differentiate, is it actually, do we now have a pancreatitis going on here, okay? So you have to be really clear. So 10 after 10, please. Okay. All right, so your book starts out when it talks about hepatitis. It starts out by talking about viral hepatitis, okay? And it's got like a little paragraph on it is all. And so under viral hepatitis is your hepatitis A, your hepatitis B, and your hepatitis C, okay? So this is kind of just that little umbrella. And basically it's a very common infection in the liver. So you do see this in people. It's the most common infection of the liver, actually. And this can either be acute or it can be chronic, depending on which one you have. So hepatitis A is usually just acute, it's self-limiting, you get rid of it. But hepatitis B can be chronic, and hepatitis C, sometimes you don't even know you have it until a long time. But hepatitis B and C are going to be your chronic liver diseases. So basically just what happens when you get inflammation, right? It's just like an inflammation anywhere else. You get inflammation, you get swelling of the liver, and what happens is because you get that inflammation and you get that swelling, what's going to happen is it's going to potentially impact the liver's blood flow and impact some of those functions of the liver that we talked about, okay? From the cholesterol to the prothrombin to the immunity to the whatever, okay? So it's just going to impact your overall functioning of the liver. So viral hepatitis in and of itself, you have very vague symptoms. So you don't really know what's going on, and most people just present with what we call flu-like symptoms, okay? And normally with viral hepatitis in and of itself, you don't get any real damage or scarring to the liver. It's when you move farther on the line. And so when we break it down, your hepatitis is broken down into phases. And the phases are important because initially, as I said, it's called pre-icteric. What's icteric mean? What's icteric? Jaundice, right? Yellow, pre-icteric phase. This is before jaundice. So this may begin abruptly or it may come on very slowly. So again, it's very patient dependent. And basically in this phase, they're just going to say, wow, I'm just really tired, or I just don't feel good. You feel like you have the flu. Your body aches, your muscles ache, and you have nausea, you have vomiting, etc. So many times, especially viral hepatitis A, is mistaken for the flu, okay? Because that's how they normally present. You may have chills, you may have fever, those kinds of things. Then you move on in what we call the icteric phase. And this is where now the patient is jaundiced. The skin is jaundiced, the sclera is jaundiced, mucous membranes are jaundiced. Normally, this becomes evident when the bilirubin level gets to about 2.5 milligrams per deciliter. So that's kind of the low norm. So when it gets to about 2.5 milligrams per deciliter is when you're going to start seeing jaundice occur. Now again, I don't give you time frames because books always say, well, it usually begins 5 to 10 days after the onset of symptoms. Well, okay, who's going to remember that, right? I just want to know, where's my patient at in this? Are they jaundiced? Are they not jaundiced? Okay. So basically, you're going to get inflammation of that liver, and then what's going to happen when you get inflammation of the liver is the bile ducts are also going to be affected, and it's going to prevent that bilirubin from being excreted into the intestinal tract. And if bilirubin doesn't go into my intestinal tract, where does it build up? In the blood. So it just kind of keeps floating around that portal circulation and back to the liver, portal circulation and back to the liver. Hence, what's going to happen then is it's going to cause those bilirubin levels to be elevated, and then you're going to see the jaundice. So you're going to see the itching of the skin. And you have to be very careful because that skin really itches. So now you've got to think about skin integrity and skin breakdown in patients that are in the icteric phase. Okay. We already talked about the stools being a light brown color, right? Because we're not having that urobilinogen being produced, okay? And so what's going to happen is it's not going to be excreted in the stool, so it's going to circulate in the blood, and where do you think it's going to end up? In the urine. So you walk in the room, you look at the Foley bag, it looks like Coca-Cola, literally. It's that color. And I've seen it multiple times. So you walk in there and you look at that urine bag and you're like, okay, is somebody playing a trick on me or what, right? Does my instructor have a bag in there just to, fool me? Because that's what you think we do all the time. And so anyway, the urine is going to be dark colored then. So you're going to see dark colored urine. So bile is being excreted in the urine instead of going to the intestinal tract and being broken down into urobilinogen and excreted in the stool, okay? Then you go into the convalescent phase where we're starting to try to get better, okay? Now remember, this lasts several weeks. This isn't all of a sudden, I have the flu, now I'm jaundiced, now I'm better, okay? This convalescent stage can take weeks before the person actually gets better. And so your enzymes, your liver labs are going to return to normal, and the symptoms are going to subside. Because isn't that what we're trying to do now with a patient that comes in and has a problem? Our interventions and what we do are done to try to get rid of the symptoms, hence we get rid of the problem, okay? So they kind of go through these different phases, okay? The first one we talk about is hepatitis A. And hepatitis A is probably the one that you probably all have had already and you don't even know it, okay? You probably had it already and you don't even know it, all right? So, what, you already had this? No.
Overseas, I probably had it.
Yeah, overseas, you probably had it, didn't know you actually had it, okay? So it has a mild course similar to that of the flu, and that's why it often goes unrecognized. It's usually transmitted when somebody puts something in their mouth that's been contaminated with fecal material. So that's why when you go into a restroom anywhere, what does it say? Employees must wash their hands before returning to work, okay? So it's transmitted fecal oral route. That is the most common mode of transmission, okay? So anyway, common sources are like shellfish that's been in contaminated waters, okay? Food contaminated by food handlers that already have the hepatitis A, So those are some of the common modes of transmission, okay? So it does replicate in the liver, and then eventually the patient will become symptomatic, okay? So the key for all of this is hand washing, because hand washing is the most important, because this hepatitis A is a very little hardy virus. It loves to live outside. It can survive up to a month outside the body at room temperature. So it can survive up to a month at room temperature. That's a long time, okay? And basically it's destroyed by bleach or temperatures greater than about 195 degrees. Well, I'm not putting my hands in 195 degree water, although, I don't know, they say your skin can tolerate a lot. But anyway, it's a very, very hardy virus. The other thing that you have to think about with hepatitis A is that it's not just fecal oral route that way, but poor sanitary conditions, right? Think about that. So then there's like less septic systems, wastes are going into the waters, right? We don't have a place to wash our hands. Crowded situations, right? We already talked about that. Daycare centers. Why daycare centers? Diapers, babies, right? Babies. So basically, the recovery is usually complete. And as I said, this patient presents with flu-like symptoms. And unless you say to the doctor, well, I've been overseas and I've been in, countries that have poor sanitation or poor living conditions, are they going to do labs for hepatitis A? No, because it's self-limiting, which means it goes away on its own, okay? That's what self-limiting means. Your body takes care of it and it goes away on its own, all right? And as I said, assessment findings, you usually don't get down here with hepatitis A, but I wanted you need to think about this. They're because of the toxins that are being released by the hepatitis A virus. That's what's causing you to get that nausea, the vomiting, the GI upsets, those kinds of things, the abdominal pain. And it rarely progresses to necrosis of the liver, very rarely, if ever, causes cirrhosis of the liver, okay? And as I said, that's because this is self-limiting. According to the literature, and I mean, there's always that little thing, but once a person is infected with hepatitis A, they're immune for life, because what's the body developed? Antibodies, okay? So if you get it, you're immune for life, okay? All right? So it's these are some of the symptoms that you're going to see. They're flu-like symptoms. Obviously, when you look at these, these are sort of like your pre-icteric, right? So when you're thinking of those stages, you're thinking of the mild flu-like symptoms, whatever, and then you get to your icteric stage where you have the jaundice and the clay-colored stools and whatever. So this is sort of like your pre-icteric, and this is your icteric phase if you even get to that part with hepatitis A, okay? A lot of people, when they come back from foreign countries or they're in the foreign country, a lot of them have a lot of nausea and vomiting, and that's why they think they have the flu. Hence, what they actually have is hepatitis A, okay? All right, lab assessments are real simple with hepatitis A. Okay, so basically it's diagnosed when we are looking for different immunoglobulins. Remember I said IgM means you're mad because you have the disease, you're glad because it's gone. So basically this is the antibody that against the hepatitis A. If you have it, the IgM, you have the acute. If you have the IgG, then you have immunity. Now, what you have to understand is these IgGs don't develop overnight, okay? So when you're looking at what we're talking about, especially like with hepatitis B, it can take several months for those antibodies to start being developed. So it's not, okay, I have it, now I have an antibody tomorrow. It doesn't work that way, okay? So it takes a while for these antibodies to develop in these people, okay? So those are the only two labs. You're mad because you have the disease, and the IgG, you're glad it's gone, okay? The IgG is what persists in your blood or in your body that gives you that permanent immunity. But it can take 6 months or longer for this to convert to the IgG, okay? So it can take over 6 months for your body to do the conversion from I have this IgM to your IgG, which is your good antibodies, okay? So it can take a while for that to happen, okay? So those are the two labs that they're going to do when we're looking at hepatitis A. When you're looking at treatment for hepatitis A, there's really no specific treatment. Patients are usually not hospitalized. The doctor will always say no alcohol, okay, because my liver's not working like it should. And they're going to try to watch the medications that they give you because the liver's sick and the liver has to try to break it down, right? And if the liver's sick, it can't break things down as well. So basically the goal is to rest the liver. So I got to rest the liver. I don't want to give it, when the liver's sick, I don't want it to have to work harder because it's going to get more sick, right? So one of the goals is to try to rest this liver so that it can heal and it can get better. So when you're looking at goals, that's one of them we want. And another goal is I don't want complications, right? I want this person to get better and not have complications. So I need to rest because rest is going to decrease the metabolic demands on that liver. Okay, bless you. And it's going to increase the blood supply. And I need blood flow to the liver, right? You want blood flow to the liver. So rest is going to reduce the metabolic demands placed on that liver, and it's going to increase blood flow to the liver. Now, a well-balanced diet is important, but when you think of a diet, you want a little bit at a time. Small, frequent meals, not huge meals, okay? We always want to feed these patients, right? And that's okay. But my liver's kind of not feeling very good. So do I want to stress the liver out? So it's small, frequent meals. It's usually high in carbohydrates because that's where I'm going to get my energy from because I'm kind of hypermetabolic right now. And I'm going to, bless you, decrease or have moderate amounts of protein and fat. And I don't feed them anything until they are no longer have anorexia or nausea, right? So if they're nauseated and anorexic, I'm not giving them anything. I'm going to give them Zofran, right? Or Phenergan or Vistarol or some kind of antiemetic, but I'm not going to be feeding them until they're no longer nauseated and vomiting. So hence I need IVs, right? I need IV fluids. So I've got to hydrate this patient somehow. And again, you've got to be very careful with medications because I want my liver to be able to heal, and you're going to have to monitor liver function tests on these patients, okay? So those are some of the things you need to think about in patients with hepatitis A, okay? So as I said, it's very rarely fatal. Most people just recover without anything at all. So it's just supportive treatment, basically, is all we're doing with hepatitis. We're treating the symptoms the patient is having with hepatitis A, right? Make sense? Okay. There are vaccines that are out there for patients with hepatitis A. There's a couple of things that we can use. Those are the different vaccines that are out there. The Havrix, the Vaquata, and Abaxum. They're single dose vaccines that are out there. And you don't have to memorize how many doses and, you know, all that kind of stuff. But basically, they say to get these, especially if you know you're going to be traveling someplace where this is a possibility that you can contract hepatitis A. You should try to get the vaccine before traveling to countries like Mexico, Central America, Asia. I know you're all going there over Christmas break, so make sure you get your Hep A vaccine before you travel, okay? Since I know you got that all planned for your graduation, right? Okay. Hepatitis A vaccine is not a live virus. It is not a live virus, so the hepatitis A vaccine can be given to people that are immunocompromised, right? Because it's not a live virus. And it can also be given to pregnant women, okay? And it can also be given to patients with HIV, right? Because they can or may not be immunocompromised, okay? Okay. Now there is, well, I'll tell you about that later, okay? So anyway, evidence-based practice says the vaccine is good for about 15 to 20 years. I don't know if that's going to change or not. If you don't get vaccinated soon enough before you travel, then what I'd like you to do is not only give immune globulin for post-exposure, but they would like to give it to you before you go. So they recommend, 1 month, all right? Don't wait. If you're leaving next week, they'll give you the hepatitis A vaccine, but they're also going to give you immune globulin. Because what's immune globulin giving me? It's giving you the antibodies. That's exactly what immune globulin is. It's giving you those antibodies, all right? Normally we give it for post-exposure, okay? But if you know you're going someplace and you haven't gotten the vaccine soon enough, they tell you that to get the immune globulin because it will provide immediate temporary. It's only temporary. You need the vaccine for permanent, okay? Or have hepatitis A, okay? Those are your two options. So this is recommended for people who do not have antibodies yet to hepatitis A. And there's a potential that they have been in close contact with somebody, so we can give them this immune globulin. It is recommended, as it says, to give it within 2 weeks of exposure because of the incubation period time for hepatitis A. And again, post-exposure prophylaxis. So it's temporary passive immunity, okay? Temporary passive immunity. So if I know I have been exposed to it, then I'm going to give both of them, okay? Yeah, I went there and, I was exposed to hepatitis A, they're going to give me both of them, okay? If you're going to travel and you don't get the vaccine a month before you go, they're going to give you this too, because you have to have at least a month for your body to even start thinking about being nice to you and giving you some antibodies for the hepatitis A virus, okay? Does that make sense?
It just happened at the Renaissance.
Did it?
Hear about that in the-
No.
Yeah,
What happened?
there were workers, yeah, there were workers that were diagnosed with it or whatever, so they were telling
Oh.
everyone who went to the fair.
Oh, I didn't hear about that.
It was like Labor Day weekend, they
Oh.
to go and, get your vaccination and then.
Yeah, they had to have
put a
both,
date on it,
'cause
and
they were-
said, no, you need to have it done by a certain date, but
Yeah.
it seems like it was like 3 weeks or so.
Yeah, 2 to 2 weeks usually, but yeah.
Just happened.
There you go, Michigan. Don't even have to go anywhere. There we go. So get it just for staying in Michigan after you graduate, okay?
You can get it from like hurricanes too, all the flooding.
Yeah, absolutely. Yeah, and that's a good point because what's happening with flooding? Sewage is getting in the water, right? And so fecal material, fecal oral route, so all that sewage is being, look at her face. Ugh, you should see her face over there. She's making all these faces. So fecal oral route. So wash your hands, okay, really well. But like I said, we've all probably had it already and just don't know it, especially if you've traveled someplace, whatever. So, all right. Good hand washing obviously is number one. You always want good hand washing with these patients for prevention. So make sure you always do a good job of washing your hands too. Okay. Don't you? I love to watch when I'm in the restrooms at restaurants and employees come in and, you're thinking, okay, 20 seconds, come on. And you're just going, okay, don't say anything, 20 seconds. 5 seconds later, you're like, they're not my waitress, thank you. They're not my waitress, okay? So anyway, those are just some ways for prevention, so I'm not going to get into that. All right, hepatitis B is probably the big one. Hepatitis B has a lot more information that you need to understand than Hep A, because Hep A is the flu, basically, okay? So hepatitis B is a virus that's transmitted primarily through blood. All right. I have all different ways that it can be transmitted, but it's transmitted primarily through blood, but it has been found in vaginal secretion, semen, saliva, and some other things. So they consider it to be, quote unquote, in my terms, a sexually transmitted disease. So you can get this through unprotected sexual intercourse with somebody who's infected. all right, because it has been found, as I said, in vaginal secretions and semen. So again, know your partner is the best thing that you can do. Other risks, obviously, the biggest one is blood. So what are you doing in the hospital, right? Universal precautions, be always very careful. That's why we've gone to needleless systems as much as possible now. But I always think of lab personnel, right? Because they have to have a needle. Unless there's some miraculous way they can get blood without a needle. That would be wonderful, wouldn't it? But anyway, blood, that is, like I said, one of the most common ways that you can get it. So risk factors are things like contaminated blood, unprotected sex, healthcare workers, hemodialysis, right? Think about that. All right, so hemodialysis, IV drug use, tattooing. I didn't have that on. Oh, I do have tattoos on there. Okay, tattooing is on there, whatever. So this is a bloodborne pathogen. It has a very long incubation period. So that's one of the bad things. And it replicates in the liver. And so it takes a long time for that virus to replicate in the liver. Hence, it has a long incubation period. So the problem with this is that the person can transmit the hepatitis B virus to you before the symptoms are even present. Okay, so they can be asymptomatic and still transmit this hepatitis B virus. So that's kind of critical when you're thinking about that. So this can progress to cirrhosis of the liver, and it can also progress to liver cancer. So some people will be chronic carriers, and those are people who don't develop immunity. These are people who are always going to have that hepatitis B surface antigen floating around in their blood 6 months later.
And they can still pass it even if they're not symptomatic.
Correct. And then they can still transmit the disease. So they can infect others, bless you, even though they are not sick and have no obvious symptoms. Okay? So your chronic carrier people become the kind of people that have the hepatitis B surface antigen. AG is bad, right? So AG is bad. We don't want that. 6 months post, if that titer is still high, that person is a chronic carrier. Okay? That's how they know if this patient is a chronic carrier. So carriers can affect people also, even though they are asymptomatic. Okay? So carriers can also infect people even though they are asymptomatic. Does that make sense? Okay, so I think that's important for you to understand. Okay, now most people with hepatitis B will develop antibodies and recover spontaneously, but there are those people that do not. So we always have to think about those people. Now, actually, when you look at the literature, they actually say that this is more infectious than HIV. When you look in the literature, the evidence-based practice says hepatitis B is more infectious than HIV. Interesting, right? And you worry about the HIV patient, but you don't worry about the hepatitis B patient, do you? As much. But this is actually more infectious, so you need to really think about that. Most of the damage is caused by the body's response to the infection. And because of the infection, the liver cells in the body become damaged, causing inflammation. And when those liver cells become damaged, then the enzymes, right, leak out of those hepatocytes or those liver cells into the blood. And that's why you're going to see elevated enzyme levels. Okay, so that's why you see those elevated enzyme levels. Then it's going to prevent the liver from performing some of those functions that we talked about. So that's why I need to be concerned about blood clotting, right? I need to be concerned about what's going on with that bilirubin level in my body, correct? So you need to think about some of those kinds of things when you talk about this patient. Signs and symptoms basically are the same as the signs and symptoms that you're going to see for a patient with hepatitis A, okay? So the nightmare labs, okay? The nightmare labs, I'm going to tell you, you're going to have to go home and think about this. Okay, you're going to have to go home and think about it because this is not easy to understand, these labs, all right? I don't know why they have to be so complicated, but they have to be complicated. So I just need how many colors? 1, 2, I don't know, I got enough colors. But anyway, I don't think I have enough colors because my purples never work. Okay. So when you're talking about hepatitis labs, okay, when you're talking about hepatitis labs, this is going to be the titer. And what's the titer? What's the titer mean? It's the level, right? It's the level. It's just done in titers, okay? And then this down here is going to be time. All right, and I'm not perfect with the time, but this is like 4 to 8 weeks starting, and then you have 12, you have 16, you have 20. This is how long it takes people to get these antibodies to develop. 28, 32, 36, 40, 44, way out to 52 weeks, okay? Long time. That's up to a year, okay? So basically, when you talk about these labs, one of the labs that we want to talk about is your hepatitis B surface antigen, okay? Your hepatitis B surface antigen. So when you do your hepatitis B surface antigen, okay, so this is hepatitis B surface antigen, all right? So this is basically about 1 month after you get infected. This is going to be the first thing that rises, is your hepatitis B surface antigen, okay? That's the first thing that elevates, okay? Does that make sense? Okay? So that's the first thing that's going to elevate. What this is going to tell me is I have an acute infection, all right? Because it's an AG, it's bad. So I have an acute infection. If this lasts longer than 6 months, then what do I become? A chronic carrier. So 6 months later, if I draw a hepatitis B surface antigen level, and it's still elevated, that then becomes chronic carrier state. Okay? So the hepatitis B surface antigen is the first to rise. Okay? Usually about 1 month after you get the infection, all right? If it's longer than 6 months, then you become what's called a chronic carrier. Now remember, these chronic carriers, even though they may be asymptomatic, can still transmit, okay, the disease to you, okay? So chronic carriers can still transmit the disease. So the hepatitis B surface antigen is the first thing that rises. So it's the earliest sign of the active hepatitis B infection. Bless you. After 6 months, we become a chronic carrier. Okay. The other one that rises, what did I do with my markers? I wish I had more colors. The other one that rises at pretty much at the same time, a little bit later, is something called your hepatitis B antigen, okay? So this is the hepatitis B antigen, okay, E. So that starts to rise about the same time, but then starts to level off at about 4 months, okay? Which I don't care, I'm not going to test you on months, I just want you to think conceptually about this. So that one is going to rise too. Now, this one really, truly has no clinical value, and here's why. This is telling me that you're highly infective. But I already know that, right? Because what do I have? The surface antigen, okay? So when you're talking about the hepatitis B virus, you have the surface, okay? You have the envelope or the E, and you have the core, okay? That's what you have when you're talking about this hepatitis virus. So you have the surface antigen, okay? You have the E antigen and the core. So infection, okay? So when the hepatitis B antigen is elevated, you know, this also is telling me the same thing. I can transmit it to others here, right, with this one. I can transmit it here. But what the literature says is if this one is positive too, this patient is highly infectious, okay? But I don't need this because I know that here, okay? Do you understand what I'm saying? That's why they usually don't even draw this in clinic. So when you're in the hospital, this one they don't even draw because it's telling me basically the same thing, right? that I have this infection. So it's basically telling me I have the same thing, okay? So this is the E antigen is bad. So they both kind of rise together, all right? So the A and the B. So the first one to spike is the surface antigen. The second one to spike is the E antigen. All this means is these are both infective, okay? These are both infective. Infective, which means I can transmit to others, okay? That's all it's telling me. Does that make sense? And just know AG is bad, AB is good, right? Conceptually, okay? Does that make sense? Okay. The other thing then that you start to see happen is you have another one, and we have the core, do we not? Right? So we have the B, we have the E, and we have the core. So the core starts maybe about week 12, okay? So the core starts maybe about week 12, okay? And then what you're going to see is you're going to see that the bad core, the AG, okay, the AG, the core AG, right, is going to start to level out and go away because what's developing right here? Okay, this is where we're starting to get antibodies to develop. But here's my problem, okay? You see this part right here? This is called my window period, okay? This is called the window period right here, okay? Because what don't I have yet to this? I don't have that IgG, right? All I have is the IgM. Because that's what the IgM is mad because I have the disease. I don't have antibodies to either one of these yet, do I? Okay? So now my core is starting, and look where the core is during the window period, right? So during the window period, the only thing that you're going to be able to find out about is the core, because I haven't done anything here. I don't have antibodies developed yet to the AG. I don't have antibodies, to the S or the E. So what's happening now is this is my core, okay? So this is my core. Okay, this is the hepatitis B core right here, and this is my window period. Okay, so what's happened is that this now has dropped. My hepatitis E antigen has dropped, correct? You see that? And so now with this window period, which lasts about 1 month, that's a pretty long period of time for a window period, right? What you're going to see is you're going to see actually IgM to the core. So hepatitis B core IgM, meaning you have the disease. That's the only thing that's going to be available there. The reason for that is that all of the antigens now, right here, that were here, right, all of your S and your E antigens are starting to be bound with an antibody. But the antibodies haven't formed yet. So that's why they're not detectable here. Because they're not free floating anymore. They're bound to an antibody. And so what's going to start happening is what? What are we going to start doing? What's going to start happening? What color is that? Pink, red. So what's going to start happening? Okay, right. You're going to have signs and symptoms. But what's going to start happening here now, right, is I have this window period right here. And then what's going to start happening is what antibodies am I going to start to develop? Right? But how long can it take? A long time. Okay? So I'm going to eventually start to develop antibodies to this. Do you see that? So I'm going to start to develop antibodies to the hepatitis B surface. Then the other thing that I'm going to start developing antibodies to, right, is I'm going to start developing antibodies to what? If I have an AG, I want a AB, correct? You always want an AB. If I don't have an AB, what's it going to tell me? I'm a chronic carrier, okay? So my hepatitis B surface antigen and my E antigen are the first to rise, okay? Clinically, no need to have the E because this is basically telling me the same thing, okay? They're both infective. So this clinically has no value. You hardly ever see this. What you see is this. This is the titer they draw on you to see if you're immune to Hep B, right here. The hepatitis B surface antibody is what they're looking for in you when you had those titers drawn. We had to have them all redrawn too, okay? So this is what they're looking for right here, okay? All right? So then eventually I'm going to start making antibodies, but the problem is this window period. I don't have any antibodies to this yet. So the problem with this window period is if I draw this, it's going to be negative because it's already dropped down. If I draw this, it's going to be negative. So the only one you can draw in the window period is the core. Okay? The only one you can draw in the window period is the core. Because the rest of them have already, their levels have already dropped down, and now they're bound with an antibody, so they're not detectable during that window period. Okay? So they're not detectable during that window period. So the first antibody, the first thing you're going to see then is this IgM to hepatitis B core. Then eventually you're going to see your surface antibody develop. Okay? Then the next thing that you're going to see is you're going to start seeing antibodies to the E develop. Okay, so you're going to start seeing antibodies to the E develop. So this would be your hepatitis B E antibody. Okay, and then eventually this is going to be your hepatitis B core antibody. Okay. So that's basically, I know that's confusing. That's why I said you have to think about it. But when I have a B, an AB, what does an AB tell me? Recovery, right? You've had it and you've recovered. If I don't have an antibody, I haven't recovered. Okay? So if I don't have an antibody, I haven't recovered. So the core is telling me right here that I still have that acute infection, right? Because IgM is mad because you have the disease. Because the core rises later. Don't ask why, who knows, but the core rises later. That's the only thing available in this window period. So if I don't draw a core in this window period, I'm going to tell you you don't have Hep B. Okay, because I don't know that. Because it's the only thing that's available right here. Because these have dropped now and they're binding with antibodies to try to form, right, over here.
If they drew a core 6 months later and it was positive, would you be a chronic carrier if they didn't draw?
A core would not be a chronic carrier.
just
The chronic carrier
the surface.
state is the surface.
Okay.
Okay, not the core. Okay, just the surface. And all it is, all these are is proteins that are on the surface of the cell. That's all it is a protein. Okay, but no, the core does not. The one that shows chronic carrier state is this right here, your hepatitis B surface antigen. Okay, so again, when you get to the AB is going to tell you two things. That's what I said, you guys. Put the notes down and look at me. All right, because you're never going to understand this. So don't be talking, looking at me, or you won't ever understand this. And you got to go home and you got to think about this, okay? You're not going to learn this just from me. So focus for a minute, then you can take notes, okay? Because otherwise you're not listening, you're writing, all right? First one to rise, hepatitis B surface antigen, okay? 4 to 8 weeks, okay? Same with the hepatitis B E antigen. All both of them mean is you have the disease, okay? So if I draw labs in this period of time, these are going to be positive, right? And all they're telling me is that you're highly infective and you can give it to other people. That's all it means, okay? That's what that means. So that when the E is elevated, okay, that's telling me I have the virus. That's it. And that I can give that virus to other people, that I can transmit it. The surface antigen is telling me the same thing, right? You have an acute infection, I can pass the virus on. Then what happens is you have another one called the core, okay? When the core rises, the core is the only one available during this window period. The reason it's the only one available during this window period is because the antigens levels have dropped, okay? And so now what's happening is these levels are not high in the blood, because now what they're trying to do is form what? Antibodies. Right. So now antibodies are forming with those antigens, so they're not available in the blood, okay? So So the only one available during this 1 month window period is this core. So if you're in this window period when you come to me and I draw these, they're going to be negative. Okay? So I got to draw the core. So they usually will draw the surface and the core. Because this one's telling me, what, I don't need this one. It's telling me the same thing basically this one is telling me. Okay? So I basically draw the core. Then what starts to happen is about 24 weeks down, then you're starting to develop antibodies to this antigen, right? Then you're starting to develop antibodies to this antigen, okay? And now you're getting antibodies to the core, okay? That's all that happens in this. So when you have the S and the E, that's telling me I'm highly infective. Now the other thing that tells me, what would this tell me? The hepatitis B surface antibody tells me two things. What does it tell me? I've either had it and I now recovered, or
Vaccine.
I've had the vaccine and I have immunity, right? Because that's what we're looking for. That's all that means, right? You get antibodies because you've had the disease, okay? All right? Or you've had the vaccine. Now, the vaccine, I got all kinds of literature on this new vaccine because now there's a new 2-dose Hep B vaccine for adults, but the vaccine isn't always effective, all right? And there's a lot of controversy in the literature. What do I do if this vaccine is not effective? Do I booster? Do I booster? Or do I booster? Or do I give them the series of vaccine again? So the literature is actually saying to go back through and do the vaccine series again, all right? And that last Hep B vaccine is the most important to provide permanent or long-term immunity. So you can't miss that last one, okay? All right, so do you understand what those mean? The C here is telling me I have an acute infection, right? It's the only one that's available during the window period. This never goes away because it's in the core or that nucleus in that DNA of that cell. So this one never goes away, okay? So if you have hepatitis B and then all of a sudden it flares up, guess what's going to come out again, right? So this one you'll see that again in flare-ups, okay? So this can tell me too, if I have antibodies, since this never goes away, what will this tell me? This never goes away. Well, not necessarily that you're a chronic carrier, but I've had the infection in the past. The chronic carrier is only this one, okay? So if this is present in the blood, let's say I'm all done hepatitis B and I've recovered, okay? If I want to know if somebody's had hepatitis B in the past and they're asymptomatic, right here, because the core never goes away. Never goes away because this is like in my DNA, right? It's in that nucleus. It never goes away. So the core is going to tell me past infection. So, it means that you have chronic Hep B. This is what the labs will check your blood for.
That would be, if it was later, it would be the antibody that would be present, right? So before antibody, not before antigen.
Right,
If it was later, okay.
right. And this is what blood banks test for. They test for this antibody because this never goes away. Okay? So blood banks, when they're screening blood, this is what they're screening because these two are only present when? When I'm sick and I'm symptomatic, right? The SAG and the EG tell me what? It's acute infection. Okay? Then I develop antibodies. All right? So this is the antibody that never ever goes away. Okay? So this is the one the blood banks are testing for because it's easier to test for this. Yes, you have had it. Because some people have it and it goes away. Some people become chronic carriers, okay? I don't know why. They don't know why I'm a chronic carrier and you're not, all right? So this is the one blood banks are looking for to see if you have had hepatitis B in the past. If you had hepatitis B, they're not going to let you give blood. So that's what that core is looking at. That's what that core is telling you, okay? So This again is the one that's persistent for life, okay? Never ever will go away. And your hepatitis E antibody, right, is telling me what? I'm not infective anymore, is basically what it's telling me. So your antibodies are telling me, okay, you're no longer infective. So that's all you have to understand, all right? I'm infective here, right? So then I have this window period where the only thing that's there now is that core. So that's what I would want to draw in this about 1 month window period, because these aren't available because the body's taking them away because it's trying to make the antibodies, okay? If these antibodies here don't develop, what do I end up with? Chronic carrier, okay? Because what's going to persist? This will persist in my blood.
So if they drew the surface antigen initially and it was found that you had it present, would they draw it again later to make sure you weren't a chronic carrier? Because what if you were acute and they just didn't know? You know what I mean?
Well, it just depends on how the patient's presenting, okay? So, because when you're a chronic carrier, you can have flare-ups and become symptomatic again. And so that's, if you have this, okay, and they know you've had it, and then, you know, a year later, you're symptomatic again, absolutely, what are they gonna do? They're gonna draw it to see if you are that chronic carrier or you're not that chronic carrier. The only way I'm gonna know is by that lab, okay? So those are basically the labs, and I know it's kind of, you know, whatever. It's hard to understand them, but you gotta sit down and you just gotta think, what's an antigen and what's an antibody? Antigen means you're infective, antibody means you're not. And the only difference is that core is the only thing that's present during that window period. So that's what I would have to draw to see if you have something going on right now, okay? And so that's, I know that sounds confusing, but that's basically what happens. So basically what's gonna happen is these are sort of gonna clear from the blood, these two, right? They're gonna kind of clear from the blood, hence you have that window period. And so that's why we have to draw this, okay, the hepatitis B core antigen, to find out if you have something going on right now. And then we're hoping that these antibodies develop. Hi, how are you? Good, he's taking pictures of everybody, just so you know.
Nope, I made sure there's no one in it.
Oh, there was, how could you not get people in it?
Well, I know that's fine. I digress. I've been afraid to ask, but what is the dotted line for? I haven't referenced that again.
Oh, this dotted line, I'm just showing you that this hepatitis B core antibody, okay? This is, all right, so now all of a sudden, remember how these drop out?
Yep.
So this is where the antigen is starting to drop off,
Okay.
okay? So this, right here during this, right after this window period, you start to see this drop off and the antibody develop. Good question.
Second question, actually.
You only allowed one a day.
Oh.
Sorry.
Okay.
Next person.
You want us to focus on the concept of the rise and fall of these versus the values that they carry.
Absolutely. What does it mean when the surface antigen is elevated? What does it mean when the E antigen is elevated? Okay. What's the concept with the window period? What's happening during that window period? How would I know during that window period whether or not this patient has hepatitis B or not have hepatitis B? Okay. What happens? What do the antibodies mean? Okay. So obviously this means recovery or you've had the vaccination. What happens if this continues to rise 6 months later? Do you understand what I'm saying? That's how I want you to think about it, okay? Does that make sense? Okay, so if you're still positive for this 6 months later, you're a chronic carrier, okay? So you're a chronic carrier. So does that make sense? Okay, does that help a little bit? I mean, you got to study it. It's not something you can just sit down and, you know, because I had an exercise that I usually do with labs, and I said no. These are too difficult to understand. So we okay with that for now anyway? Okay. Good discussion board topic, labs. All right. Did that help graphing it out a little bit?
Yes.
Versus just that's why, see why I don't like PowerPoint? Doesn't do the same thing. Can't do the same visual. Okay. All right. All right, so what are we going to do? How do we treat somebody with hepatitis B? Okay, well, treatment, there's really no medication available. Again, it's supportive treatment is what we tend to do most often. However, if they're chronic, then we do regular monitoring, okay, on these patients, hence the more frequent labs, and we give them some antiviral drugs. So basically, what I want to try to do is I want to protect my liver, okay? I don't want to end up with liver cirrhosis or liver fibrosis or decreased liver function. So what I want to do is I want to protect that liver. So that's one of the goals of medical management. The other thing we try to do is we try to decrease the symptoms, and we do that with supportive treatment, right? And you know what that means, correct? If they're nauseated, give them antiemetics. If their skin itches, give them, because of pruritus, give them something for itching of their skin, you know, etc. And it doesn't always have to be medications, okay? So those are just some of the things we already talked about, right, with hepatitis A, but we'll get a little more into medications with Hep B here in a second. So what are we trying to do with drug therapy? Decrease viral load. So you're going to see some medications that kind of look familiar to you when we go here a little bit farther that we've already had, correct? Your nucleotide meds that we learned with HIV and AIDS, right? You're going to see some of those come back in the picture now with these patients. So the whole goal is to make sure that we kind of spare and save the liver. That's what we want to try to do, okay? We want to try to save. So there are different medications that we can give to these patients. And of course, I'm putting both names. And I will on test put both names, trade and generic, for you. Okay, we have the option to do that, and I will put both for you. But, you know, bear with me, learn them both, because there are times where I'm looking at it and I may forget to put the trade name. So I'm just going to let you know my goal is to put both, but sometimes, you know how you read something and you think you read it and, you know, you look at it again and it's like, I didn't even see that word, like if you're taking a test, right? So I kind of go into that mode. So anyway, when you talk about, there's, like I said, there's no specific thing that we can really do for them, but we can give them some antiviral medications to help fight the virus and slow down its ability to harm or damage that liver. So a couple of the meds that we give them are interferon alpha or intron A, or pegylated interferon, which is pegintron. So those are the couple of medications that we give them. This first one, the interferon alpha, that's an entry blocker. So remember, we had entry inhibitors for HIV. This is usually the first line drug that we give these patients. And what this medication does is it blocks the virus from entering the cell. So that's the goal of the first one, the interferon, is to prevent that virus from, entering the cell. Okay. The second one, the pegylated interferon, is a biological response modifier. So a BRM, biological response modifier. And what do? Boost the immune system. Okay. Now I will tell you, you'll see questions in your NCLEX books, and you may see this on boards, that this pegylated interferon has to be given by injection, okay? Sub-Q injection, it actually says. So that has to be given by injection. Bless you. Everybody's sneezing today. Wow. 3 feet. 3 feet rule. Push the table back, please. Push the table back. Pardon me?
Fungus in the carpet.
Yeah, I know. Wasn't it? I know, they clean that lovely carpet, so we have fungus in the carpet. Okay, so basically, one of the things that you need to think about when you're looking at some of these medications is that they can cause muscle weakness, okay, so, or myopathy. So when you're doing any kind of teaching on these patients, you need to make sure that you tell them to report any weakness. Okay, all of them, but I'm getting to the bottom too, but thank you. Okay, all right, so your nucleosides, these are other meds that we give. Now what do these block? DNA replication, right? So the virus can't replicate. Now these have to be given, according to the literature, all of these meds for up to a year or longer. That's a long time, okay? That's a long time. So basically, the key though, what we're trying to do with these nucleosides then is to decrease that viral load, right? Because if I block replication, what am I blocking? The amount of virus that's in the body. Less virus in the body, less damage to the liver, correct? Less symptoms the patient is going to have, okay? So basically that's what you think about with those kind of medications, all right? So again, most of these medications are given orally down here, but again, always think of muscle weakness. Always think especially to bone marrow suppression and renal toxicity with these kinds of medications. So bone marrow suppression and renal toxicity, especially with these down here, your nucleosides. Bone marrow suppression and renal toxicity. So when you're taking care of a patient, what do you need to think about? What do you think about? What are you going to assess on your patient? Okay, intake and output. Weight. I can't.
You got an infection, Sharon? Sharon, you got an infection?
White blood cell count.
Are you a white blood cell? Hi, white blood cell, how are you today? Oh, you're a white blood cell, so I know you have an infection. No, I'm not a lab. I'm not a diagnostic test.
Symptoms of infection or signs of anemia.
Okay, fever. Okay, signs of infection right first. Assess the patient. Okay? Assess the patient. Then worry about labs later. Because what do I have to do? I have to put the two of them together. So when you think about bone marrow suppression, you think about, are they fatigued? Are they getting fatigued more than normal, right? Are they short of breath? Why? Low hemoglobin and hematocrit. See what I'm doing? I'm not saying, oh, I'm going to check your hemoglobin and hematocrit. Yeah, I need to check it. But are you symptomatic or are you not symptomatic? Okay, what would I assess in my patient? What would you assess with the low platelet count? Bruising, petechiae, bleeding gums, nosebleeds, right? Blood in the stool, blood in the urine, right? Right? Okay, and then you add the labs to that, all right? Renal toxicity. All you have to do when you think about what to assess is, I'm not getting rid of volume. So if I'm not getting rid of volume, I'm not getting rid of fluids, and I'm going to have problems with electrolytes and potentially acid-base balance, right? Because what's the kidney not able to do? Synthesize bicarb and excrete hydrogen ions. So I may have acid-base balance problems, right? So, what am I going to listen to? Am I tachycardic? What's my heart rate? What are my lung sounds like, right? Do I have edema? What's my output? Am I gaining weight? Simple. So you got to put it in perspective of what's happening with renal toxicity. I have a volume problem. I'm not getting rid of volume, correct? All right, does that make sense? Right. And I'm not going to read this stuff to you. You can read that. I'm not going to read slides. Wait a second on that. Okay, so basically my goal in prevention is to interrupt transmission of the hepatitis B virus. So that's what I'm trying to do. And so I want to protect people at high risk, such as healthcare providers, with the active immunization, right? Because that's what we need. Or I want to give passive immunization to people who can't take, right, the hepatitis B vaccine or have been exposed to the hepatitis B virus, okay? Because some people can't take the hepatitis B vaccine, especially if they're allergic to what? Yeast, so they can't take it. So blood screening, good cleaning of equipment, universal precautions, disposable equipment, those are anything that protects you from what's the most common mode of transmission? Blood. So that's what you have to think about when you think about prevention, okay? So hepatitis B vaccine, there's a bunch of different vaccines out there. And again, these do not contain the live virus. And the articles, I read all kinds of articles. You guys need to learn to read articles, right? It's very enlightening. Because you never quit learning. But the evidence-based practice from this article that I read, and I always have to read it so I don't misinterpret it, only give a booster vaccine if the patient is on hemodialysis, okay, or those who are immunocompromised. Only give, no, I'm just talking about a vaccine in general, hepatitis B vaccine in and of itself, not all of them. This is the new one that I'm going to be talking about. So all I'm saying is the hepatitis B vaccine is only about 95% effective in the literature. It's not always 100% effective, hence what you have to have drawn. Which one? This is what I'm looking for, aren't I? I want to see if you're immune, okay? Since the vaccine is only about 95% effective. What the vaccine does is promote the synthesis of antibodies, okay? It promotes the synthesis of antibodies. And as I said, that third vaccine in the normal hepatitis vaccine routine is the most important one in providing you that prolonged immunity. And I'm saying prolonged immunity because nothing is ever 100% always, right? It's never 100% always. So basically these vaccines right here, the recombinants, the Energix and the Twinrix, these are in your book. This is a combination of A and B. Basically what they do is they work by giving you protection because they have your body produce antibodies, okay? They do not contain a live virus, okay? So if they have immunity, then they're going to have a good surface antibody, okay? If they don't have immunity, then what's going to happen? Then we probably need to revaccinate, okay? And go through those series of vaccinations again, okay? So you have to give it time for antibodies to develop. The literature says 1 to 3 months after vaccination. And so that's kind of what you want to think about is you can't give them the vaccine and a week later go and draw and see what their antibody levels are going to be. Because look how long it can take for antibodies to even start developing, okay? A long time. So basically, the new one that's out there is this. And I actually got this from the Journal of the American Medical Association, okay? And this is the first new hepatitis vaccine to gain approval in the U.S., okay? So it's been a while, in more than 25 years. So it's been a long time coming. The current vaccine, right, requires 3 shots or injections over a period of 6 months, okay? The problem with that is a large number of people have 2 and don't go back for the 3rd, which is the most important one. So what's happening then is they're not getting that immunity. So this new Heplisav B requires 2 injections only 1 month apart. So that's not bad, which greatly improves the likelihood of high-risk people completing, right, their vaccination. The cost is about currently right now, I'm just telling you from what I researched last night, the cost is about $115 for the Heplisav B vaccine, which isn't bad, okay, that's not bad, where this one is only about $23 to $25. So the question is, which will insurance cover? Okay, I can't answer that question. And that's what everything always boils down to, right? Is insurance coverage. So I don't know what to tell you in relationship to that. This Hep B, the new one, it says here, is in use for adults only, 18 years or older, okay? Clinical studies, so this is the kind of stuff in your paper we're looking for, clinical studies. So they've done these clinical studies, you know, to see. They even did them by age group, and I'm not going to get into it right now, but they did them by age group, etc. And so they're finding that this was just as effective as the 3-dose vaccine, okay? But the rate of adverse effects was similar with the 2 vaccines. So the adverse effects are basically the same regardless of which vaccine you get. But the key is that, and this was February 27th, 2018. The other thing that it says, the long-term safety of this has not yet been established, okay? So, anyway, that's the new vaccine that's out there. And why do I say it does not provide protection to those already exposed? They already have it. They're good developing antibodies, okay? So anyway, the question to me is, it really remains to be determined what level of antibody is really necessary for protection, for long-term protection. I don't know that. Do you know what I'm saying? I could have a certain titer of this, and it may not be enough. Do you understand what I'm saying? And so I may need I don't know. That's what's still out there in the research that we need to think about in relationship to this vaccine. So those are the vaccines that are out there for hepatitis B. And then we have what's called the hepatitis B immune globulin. Now, what do you know about an immune globulin? We already talked about this. What does it provide?
Temporary.
Okay, temporary what? Passive, right? Immunity. So it provides temporary passive immunity. Now, the national guidelines, all right, when anything I take out of a literature, I always have to read, I'm sorry, because I don't want to say it wrong, recommend post-exposure vaccination, especially when you're not sure where you got contaminated with blood from. And that makes sense, right? Because what happens in the hospital when you're doing a procedure and let's say you're doing a blood draw on a patient and you poke yourself? What do they do with that patient? They test the patient too, don't they? So they'll draw labs to test the patient. So they're telling you if you have blood on you and you can't remember, or you got contaminated with blood and you can't remember, get this right away. Because it provides immediate passive temporary immunity. Because what I'm giving you is a dose of antibodies. That's what immune globulin is. I'm actually giving you the antibodies to the virus. So because I'm giving that to you, it will give you immediate protection. But it only lasts for a few months. So this isn't going to last for 6 months. A couple months is the most that it's going to last. Okay, so that's what they talk to you about. It says it should be given as quickly as possible, right? Because the sooner you give it, the less chance the disease has, right, of getting that AG growing and replicating in your body. So within 24 hours is what is recommended, okay? So that's what they're talking about. So vaccination in and of itself, even though you have exposure and we're doing this, they still tell you to vaccinate the patient or the person. They like you to be vaccinated according to the evidence-based practice within 7 days of exposure to start your vaccination series, okay? I'm not sure which one they're going to give you. That's up to the doctor, obviously, the new one or the other one, and it's also up to your insurance company, right? Unless you want the new one. And if the insurance doesn't cover it, you pay the $115. You know that. You know how insurances are getting, right? Nothing's ever paid for. All right. Why don't you stretch for till about 11:30? I do want to finish hepatitis before you go to lunch. And we're almost done with hepatitis. And then and then you can go to lunch. All right. Hepatitis C. Okay. Now, the thing with hepatitis C, again, is the overall picture of the patient is similar to that of hepatitis B. This tends to be transmitted more percutaneously, so these are more patients with like your IV drug use, you know. Needle sharing has the highest incidence, and you know there are programs out there where they can go turn in their dirty needles for clean needles. There is something in Saginaw County. I had a student last semester whose mom worked for the health department, and she sent me some article. So they do have programs out there for that. The problem with hepatitis C is it does its damage over decades. And when I talk decades, I mean decades. Most of the time you don't see this till later on in life. So what's happening is this chronic inflammation is going on in the liver, okay? And within chronic inflammation, you get scarring, right? The problem is this scarring in these people may end up going into cirrhosis of the liver. But the issue is that these people may have had this for years, and it says 80% of the patients with hepatitis C have no symptoms, okay, initially. And those who get symptoms, they don't understand why, but you can maybe get this in your 20s and may not even show up till you're in your 60s or 70s, okay? So they tend to be asymptomatic and not diagnosed till years later.
I know there was just a story about that. They're telling all the baby boomer era
Me.
to go, yeah, to go get tested because they've been, they've
Yep.
been infected years and years and years ago.
Nothing.
But
Yep, there
now
you
they
go.
know that they had it.
And that's what's happening, and they don't know why. Why do they not have symptoms, Because if you don't have symptoms, are you going to draw labs? No, right? So they're usually asymptomatic, and so it does its damage, as I said, over decades, and it causes scarring in the liver, and that liver may then lead to cirrhosis. Chronic carrier state is very common in this. And so what we want to try to think about in these patients are the secondary effects of the disease, like the chronic hepatitis or the cirrhosis of the liver. A large amount of population, the literature says 40 to 50% of the population have no idea where they got hepatitis C from. Okay? They say, I have not used illicit drugs, I have not used dirty needles, any of those kinds of things that you think about when you think percutaneous transmission, and the average time without symptoms is about 30 years. That just really fascinates me, okay?
My dad had hepatitis C.
Mhm.
He got it because he had surgery and they gave him a blood transfusion. And
Yep.
like back in the 80s.
Right, before they screened it.
Yeah,
Before they screened it.
for it.
Yes,
So,
yes.
That's why they're.
Yes. Well, and and that's a good point. Thank you for bringing that up. Blood screening. Years ago in the 80s, we didn't have the screening of blood that we do now. All right. So yes, you are correct. That hepatitis C, some people did get it through blood transfusion. Back then, people could also get it through hemodialysis because sometimes, the needles weren't actually sterile. That's why with tattoos, you have to be very careful that wherever you go to get tattoos, that those needles are perfectly clean. Otherwise, you could get hep C even through tattoo, okay, getting tattoos. So the highest incidence, though, are the illicit street drug who has had hepatitis C, okay? So personal items, they do say that because of the microscopic blood, that it's usually not transmitted by casual contact, but because of microscopic blood, they tell you, not to share like straight razors, don't share toothbrushes, pierced earrings even, don't share pierced earrings if, with your girlfriends or whatever. Anything that could potentially, have even microscopic blood, because all it takes is a little bit for that virus to get in your body, right? And so those are things to think about. Symptoms, again, I don't have all of them on here. They're basically the same. That's what scleral jaundice looks like. How many have actually seen it like that? You can't miss it, right? It's yellow, okay? You can't miss it. So as I said, many people are asymptomatic, and then basically the only way they find it is they go in and they have their physical, right? And you do this, they take 15 tubes of blood and they draw liver enzymes and things like that, and they find out based on lab evaluation that your liver enzymes are elevated, okay? So then they're going to try to figure out what the heck is going on with this patient. All right, lab tests, these are really simple compared to this. Keisha did a really nice drawing that, can I just share that right now before we go in this, for this hepatitis? I thought this was really, really cool, that she understands this hepatitis B very well. So what she did on her little sheet was she had hepatitis B surface antigen, okay? And then she had a bunch of little circles like this. So this is the antigen, right? Okay. Okay, so this is the antigen, or like the IgM, because you're mad you have the disease, right? And then she has this going, I have to get another color, but bear with me. Okay, so that's what she did for the antigen. And then she had like this for the core. Okay, she had that for the core. And then she had in here where what's just starting to form, okay, your IgG or your antibodies, right? So then what she did was she just did a bunch of things like this, and this is now your IgG or your antibodies. Very good. That tells me she understands this. She was able to take what I did and put it in this format. That was excellent. I'm going to steal that, okay? So I'm going to steal that. So that tells me she understands now. What else would be elevated here? The E, right? The E, and then the core, right? And over here would be all your antibodies. Very good. So I had to share that. That was very creative, okay? All right, hepatitis C labs. So blood tests basically are going to be the key to diagnosis because I've been asymptomatic. I came in for a physical. Your office calls me and say, hey, your ALT, your AST, and your ALT phos is elevated. And you're like, what are you talking about? You know, I don't feel bad. Well, you know, we got to figure out something else. So anyway, what they want to do is the first thing they want to look for is this antibody. So they want to look for an antibody, and it is a marker. So it's just a marker. It doesn't say you have it now, okay? So this is just a marker that they're going to look for, and if it is positive, all it means is you've been exposed. It doesn't necessarily mean you've had, you know, this decade-long Hep C, but it means you've been exposed, but it doesn't tell if you're infected right now, okay? Do you understand what I'm saying? You have an antibody because you were exposed and your body develops antibodies. Doesn't tell me what else is going on. So what we need to do is we need to do a confirmatory test, right? Which is the recombinant immunoblot assay or the RIBA test. It's a confirmatory test, and it confirms that, yes, you definitely have that hepatitis C antibody, okay, in your bloodstream. So a positive then means that there has been an infection with hepatitis C in the past. This one is just saying, yeah, you have the antibody, but I don't know if you actually have the disease. So I've got to confirm, and so they do this next test, and this is the confirmation test. And if this one is positive also, then it says, yes, you have, right, hepatitis C, or you've had it in the past. So basically what they need to do then is they need to draw another test called a viral load test for hepatitis C, okay? So this is just, ooh, let's just check. You're starting to have symptoms. Let's just check this out. It's positive, but, you know, let me do this test to confirm it. Yup, it's still positive. This means that you've had hepatitis C. Doesn't necessarily mean you have it active right now, but yes, you've had hepatitis C in the past. So now let's see where you are here, okay? So now we're looking at that viral load. We've talked about viral loads in the past, correct? Not a new concept. So this is going to be what confirms active infection, right? If you have a high viral load, what's it going to tell me? That you currently have active hepatitis C. They're also going to use this test to look at whether or not how they're treating you is effective or not, because I could care less about these two tests now, right? I could care less. These aren't going to tell me anything, right? What I want to know is, do you have active disease going on or don't you have active disease going on? Your viral load is high, you do. If it's not, or there's no viral load, or it's undetectable, you don't, right? Just like with HIV and AIDS. So if this is high, then I want to say, okay, now what are we going to do to treat you? And then I'm going to redraw this viral load because this is going to tell me if what we're doing is working or not. Does that make sense?
So why would they draw the first one? It seems redundant. It seems like
Because there can be false positives and things like that, and it doesn't tell you if you're still infected. All it says is exposure.
Right.
Then they redo
the
this.
second one and then the third one is-
Correct. So the second one is, yes, definitely that first test was positive.
Okay. Right. that's-
Insurance, just like everything else, okay?
You have a false positive on the second one.
There's not as much a false positive because what the second one is doing is also measuring the presence of the virus. The first one isn't measuring the presence of the virus, and the second one is also measuring the presence of the virus, but it's not giving me the viral load.
So it's pretty much insurance.
Well, yeah, with anything else. You know, you have something, you need an MRI, but they're not going to do an MRI. What are they going to do first? An X-ray. that won't even show anything, but that's what they have to do. So this is just the process that they have to go with. So welcome to insurances, okay? So, oh yeah, that's true. Yeah, physical therapy for 6 months, right, every day. Yeah, then you get the x-ray, and then physical therapy for another 6 months, and then your MRI. And that's what insurances do. So the first one, remember, is just saying, yeah, it's positive. The second one saying, yeah, it's positive, but it's looking to make sure that virus is there. Yes, you've had hepatitis C in the past, but I don't know if you still have it or it's active. This one is telling me if it's active, okay? So yes, it's just kind of redundant, isn't it? But unfortunately, we don't have that's just what we have to do. Okay, here we go with meds again, right? Same kind of stuff. Don't those look familiar, some of these meds? Our antivirals, correct? So we look at our antivirals, all right? And then we already talked about antivirals. Do we need to talk about antivirals again? Are we good with those? Remember, your pegylated interferon is subcutaneous injection, right? All right, and so you'll see that in some of your NCLEX books, all right? So you may see that on the boards, that this is given sub-Q injection. The literature says to do it weekly, but I'm just letting you know it's sub-Q injection. So the Copagus, I'm supposed to be using those, right, is oral, okay? The problem with the Copagus is it may cause birth defects, so it may not be something that you want to give them. The other thing it does is it can cause anemia, so we really need to monitor, look at this, hemolytic anemia, right? So we need to look at our hemoglobin and hematocrit in those patients, okay? Anytime anybody is on an antiviral medication, since we're talking about hepatitis, you also want to monitor their liver enzymes, correct? What's their liver doing? Okay, what's going on? Because what is that going to tell me? Yeah, is it effective or isn't it effective, right? If I'm giving them these medications and their liver enzymes keep going up, why am I giving them to them? Okay? Unless I just adjust the dose and try again or whatever, but you know, if something's not working, then why do we keep giving them? They need to take these medications that, remember I said, they can take these up to a year. Okay, that's a long time to have to take a medication, okay? So my goal is to decrease that viral load, right? To decrease that hepatitis C virus RNA. So my goal is to decrease that viral load or try to get it so I can't detect it, right? So I want it so it's not detectable, and I want to see my liver enzymes go down. That's my whole goal of treating them with these antivirals. Because I don't want cirrhosis of the liver, do I? I don't want to progress to cirrhosis of the liver because you're going to find out this afternoon that's pretty bad. Okay, cirrhosis of the liver. All right, your nucleosides, right? We talked about those. It prevents what? DNA replication. And if I decrease DNA replication, I decrease the viral load, don't I? If I decrease the viral load, I decrease potential liver damage, right? If I decrease the viral load, then I don't have liver damage, then hopefully my liver enzymes, right, are dropping. Does that make sense? Right? Because isn't that what we're monitoring? Okay. Protease inhibitors. What do protease inhibitors do? Yep, they stop it from breaking apart and forming new viruses and budding and going out into the body. So your protease inhibitors are another medication that we use. The other thing that I just want to mention while I'm thinking about it, this interferon can cause depression. So interferon, the pegylated interferon can cause clinical depression, or just depression, I should say. And it can also exacerbate mental health disorders if the patient has been diagnosed with a mental health disorder. So that's something that you need to think about when you're caring for these patients, okay? Now, what have you heard about Harvoni? Oh my gosh, it's all over the TV, okay? What do you know about Harvoni? What does it say Harvoni does? Okay, it's a combination drug, but what do they say it does?
It's a suicidal thought.
Oh, well, that wasn't what I was thinking, but All right, so it gives you suicidal, but what does it tell you it does on the TV? It does what to Hep C? It cures it, isn't that what it says? The TV commercial says it cures hepatitis C. All right, and here's the thing from the Journal of the American Medical Association on Harvoni. So basically, it is an oral medication, and it's used in patients that have hepatitis C. And it actually says in here, interestingly enough, that it is supposed to cure hepatitis C. But here's the key when you talk about this, okay? Hepatitis C cure can start with this right here. So it's for chronic hepatitis C, but the key is it's for a certain strain of hepatitis C. So what I'm saying to you is there's multiple strains of hepatitis C. So there's more than one virus that, you know what I mean, viral strain. There's multiple ones. Just like HIV, I don't teach you about all the different strains because you don't need to know that. That's for the infectious disease people. Same with this, okay? So it's only going to cure this one strain, which you don't even really, you know, need to know about. So it's interferon and ribavirin. Let's see, what else did it say? It cures 94 to 99%. Yep, for the one strain, because there's multiple strains. So that's the key. When you look at TV commercials, what is it doing to these people? Oh, I have Hep C, I'm going to be cured. Well, not if you don't have this HCGT1 strain, you're not. So you can take Harvoni, but it isn't going to help you if you don't have that, okay? So anyway, what it does is it inhibits viral replication, all right? So my question is to this, really, does it really, I mean, I don't have enough data, but my question when this first came out was, does it actually cure hepatitis C, that one strain, or does it just decrease the viral load so low that it's undetectable? Just like HIV. And I don't really have the answer to that because I be honest with you, I didn't do any more research on that. But that is always my question with these medications. Did we actually cure it? Or we can look it up. Yes. Right, exactly. And they did a viral load. Yeah. Absolutely. So I don't know. Liver transplant, right? Because this can lead to liver failure and cirrhosis of the liver. The end result with patients a lot of times with cirrhosis of the liver is a liver transplant. There is also liver dialysis available out there. You know, I've never seen it in our area, but basically, you know what renal dialysis does? Well, this is the same thing, but it works on the liver and helps filter out toxins and all that kind of stuff. Okay. Prevention, basically, right? Same kind of stuff that we do for any of the hepatitis, all right? Always follow universal precautions anytime you're taking care of any patient, all right? Nutrition, again, when you think about nutrition, what do you got to think about? Yeah, I got to rest the liver. And if the patient's symptomatic and they are nausea and vomiting, I'm not going to be feeding them, am I? You want to wait till those symptoms go away. Because the diet, again, you want to be high in calories and carbohydrates because that's what you need for energy, right? And carbohydrates are broken down very quickly, and you don't want a whole lot of fat and you don't want a whole lot of protein because the liver's struggling, right? And so when you eat a high-fat diet, the liver's not able to process or break that down. So that's why when you look at nutritional intake, we want a high calorie and carbs and low to moderate protein and fat because the liver can't metabolize proteins. And protein, carb, and fat metabolism are functions of the liver that I didn't discuss earlier, but they are functions of the liver. So there we go. Universal precautions, vitamins, right? Makes sense? Okay. And this you can, you know, research more in your book, right? Good hand washing. Vaccinations. Why would I give them a vaccination for A and B? Why would I even think about teaching them vaccinations for A and B?
Some of the risk factors are the same, right?
Right, exactly. Some of the risk factors are the same. They have the potential for getting A and B because some of the, you're absolutely right. Very good. Okay? See you about 1:45 person. All right, cirrhosis of the liver is what we're going to talk about today. And one of the things, remember, that I want you to understand is portal circulation. Portal circulation is a little bit different because we're so used to all our blood supply coming from an artery, right? The majority of your portal circulation comes from a vein, and this is your portal vein, okay? And then it goes through the liver, breaks down into smaller little things, and then your inferior vena cava. So this is all draining the lower GI tract. All that volume is coming to the liver via the portal vein. So I know it's not perfectly anatomically, but you know, I can't draw. You know, what happened there? Oh shoot, I forgot the markers on my desk. Oh darn it. Okay. So anyway, this is your portal vein right here. Of course, your kidneys are connected, your spleen is connected, then your stomach, there's little vessels that connect your stomach, you know, to this big vessel, but I couldn't draw them. So all of this is connected, okay? Hence the issue when we start having problems with cirrhosis of the liver. So 80% of the blood supply going to the liver is venous in origin, okay? It's venous in origin. And it actually drains the whole lower GI tract goes up into the liver, okay? All that volume goes up into the liver. The remainder of it comes from the hepatic artery, which is in here, like up in here, the hepatic artery, but the majority of the blood supply is venous in origin. So only a small amount of blood is supplied by the arteries, and the rest of it you get otherwise. So I just wanted you to be aware of that, okay? And I got in my little picture, because, well, this picture is better than that one. Okay, does that make sense? Sort of? You can just say yes. Yeah. Okay, thank you. Make me feel good. All right. So when we're talking, okay, basically one of the things you need to understand about cirrhosis of the liver is this is a chronic disease process, okay? So this is definitely a chronic disease process, and it is a chronic progressive disease. And basically what's going to happen is the liver is going to degenerate. So we're going to get some scarring, we're going to get fibrosis, and what the liver is going to do is shrink, okay? And when the liver shrinks, we have a decreased size in our liver, but as it shrinks, it's going to impact liver function, and as it shrinks, it's going to impact this blood flow right here. Okay, so this is the whole problem when we talk about cirrhosis of the liver, is all of this is getting impacted because of a problem going on in here. Okay, so cirrhosis of the liver, it disrupts, as it says, the normal structure and function of the liver, and alcoholic cirrhosis is the most common type of cirrhosis in the United States. Okay, so the most common problem with cirrhosis of the liver is due to I'm going to show you this picture, is due to drinking, okay? So alcoholic cirrhosis is most common. And the problem is as I said, it's a chronic disease process, and the liver normally has the ability to regenerate, right? But the problem is this is when the liver gets damaged to the point that it can no longer regenerate. And when it can no longer degenerate, it leads to all these little bumps here, or these nodule formations. Okay, when the liver is no longer able to degenerate. And basically what those are is that those are liver cells that don't die. So those nodules are caused by liver cells that don't die, that are regenerating, okay? The problem is I've got scarring all around all there, so they can't go anywhere. So what they do is they form bumps, okay? So these are liver cells that don't die. What they're trying to do is the ones that don't die, they're trying to replace the ones that did die. Okay, it's what they're trying to do. The problem is they can't spread out because I have nowhere to go because I have scar tissue. All right, so they can't spread out. And then the result is you get these little bumps in the liver, and it will start impacting blood flow to the liver, and it will start impacting the liver's ability to function. Okay, and I'll go into that a little. What does my patient present with? Well, initially, I just don't feel good again. Basically, these patients may not have any initial signs and symptoms. It's just like, I just don't feel good again. I don't feel good. I have a little achy pain in my stomach. I may just kind of be a little bit nauseous. So I don't really have a presentation where I would say, yes, I definitely have liver disease. All right, so usually you see some GI disturbances because the liver is unable to do anything with carbohydrate, protein, or fat metabolism, because the liver is active in carbohydrate, protein, and fat metabolism. And also the abdominal pain, right, is where? Okay, right upper quadrant, okay? It's in the right upper quadrant of the abdomen. So basically, again, when I look at a lot of these, except for the enlarged liver, right, you look like you have what? The flu again, right? You look like you have flu-like symptoms, okay? But later on, as the disease progresses, if we don't do anything about it, these symptoms are going to start to occur because the liver's now starting to fail. The liver's not able to perform all those 500 functions that it's supposed to do, okay? So we already talked about jaundice, right? Because we're unable to take that unconjugated, right, or direct bilirubin, or indirect bilirubin, which is bound to protein, right? It's not water soluble. For us to be able to process it, it has to be water soluble. So we had that, remember that unconjugated or indirect bilirubin? It goes to the liver. What's the liver do? It makes it water soluble, right? Well, the liver is unable to do that. Hence, what's going to happen then is that leads to jaundice, okay? It leads to jaundice. So this is just, a little picture you find. Adam's a really good site for pictures, okay? Then you get the itching because you get that the salts from the bile precipitate under the skin, and then the patient can get some itching. Ascites, we'll talk a little bit more in just a minute, but that's due to third spacing, okay? So again, you're getting edema of the extremities, you're getting a big belly. What's my concern with a big belly? A lot of fluid in my belly. Absolutely breathing, right? So you got to be very careful because as I get more and more acidic fluid, I get more, how's my lungs supposed to expand, right? How are they supposed to expand? They can't go down very far because I got this big bowl of water sitting there, right? So respiratory is a huge problem in patients that have ascites. Skin lesions are another problem that you see in these patients. And I've got some pictures, I think, on the next couple of pages, maybe, right, of some skin lesions. But basically what's going to happen, remember that cholesterol is important for the manufacture of hormones like estrogen and testosterone. And the liver actually excuse me, the liver actually metabolizes those hormones and those steroids. But when the liver is not working anymore, it's unable to metabolize them and use them, so they can be used like they're supposed to. And so what happens is the skin lesions are due to the fact that we have way too much estrogen in our body. So the skin lesions are related to increased amount of estrogen floating around in our body. And then we start seeing some problems, okay? Hematological problems, right? Thrombocytopenia, right? Why are we getting thrombocytopenia? What's the liver not able to do? Okay, coagulation factors, right? Now, what's the spleen do? Okay, it removes old red blood cells, right, from the blood supply, okay? And it removes, stores, and produces lymphocytes, right? Remember that? And these lymphocytes are stored as antibodies. So the spleen is unable to do that. So when we start having liver problems, and we'll go to this in a second, but when this blood flow can't go through like it should, we get what's called a collateral circulation because everything goes back. Okay, this is all considered collateral because collateral is just another pathway, right? Like with an MI, they get collateral circulation forming below the area. Well, this is where all the blood has to go, is in this collateral. So what's going to happen is the spleen can become enlarged, right? And you can get splenomegaly. Well, the spleen doesn't appreciate that, and so what it does is it increases the rate in which it is going to remove red blood cells, platelets, and white blood cells from circulation. So the spleen increases the rate at which RBCs, WBCs, and platelets are removed from the circulation and destroyed. Hence, thrombocytopenia, leukopenia, anemia, coagulation disorders. Okay, so it increases the rate in which all of those blood cells are removed. The RBCs, the WBCs, and the platelets. So it increases the rate in which they are removed from the blood and destroyed. So this is what happens. These are the symptoms that you see. Okay. Thrombocytopenia is usually the first clinical sign that you see in these patients, is all of a sudden they have a low platelet count, and that's one of the first things that you're going to see. So those are some of the later things you're going to see. Here's your skin lesions, the spider angiomas. Where do you tend to see those? The nose and the face, yep, the chest. You see them very common in your alcoholic patients too, do you not? Because remember, alcoholic cirrhosis is the most common cause, or alcoholism is the most common cause of cirrhosis, or alcoholic cirrhosis is the most common cirrhosis that's out there. So these are just small dilated blood vessels. So, you know, it's supposed to have like a little body here, and they tell you it looks like a spider, okay? Well, I hate spiders, so I don't know about anybody else, but they're creepy little things. So that's what happens. And then you see them in the nose, you see them in the cheeks, you see them on the trunk or the upper chest very commonly. And that's basically just due to the liver's ability to metabolize your steroid hormones, okay, your estrogen especially. This is what's called palmar erythema, okay? And basically when the person looks at their palms, the beauty is their palms are going to be red like that, but they still blanch, which is a good thing, right? So basically what happens, it's redness that blanches with pressure, and it's located on the back of the hands. And again, it is just a result of the liver's inability to metabolize those steroid hormones. So everybody look at your palms. See if you had too much to drink this weekend. All right? I know some of you are in clinical, so I know Sherry's patient had too much. Check his palms next time. Okay? Say, I look at your hands, please.
Yeah, like,
Just had drank a fifth of vodka in his room that day and had alcohol, so they drew a blood alcohol level, and it was a little high.
I don't know if he brought it. He never told us how he got it. I don't know if he brought it. I don't know if his mom gave it to him. So I feel like he must have brought it in. I'm like, how long did he get up there then?
Yeah, how does he get up there? Is just walk off the elevator
Yeah.
into your room. Here comes a bottle on legs, you know. Can you send me another one, please? Yeah, I'd like to order another bottle on wheels, please. You know. All right, some other manifestations that you see later on now is the coagulation problems. And remember, the liver needs to be able to produce prothrombin, right, and fibrinogen. And so now what's going to happen is we're going to start seeing some of the things that you see with bleeding. Now, what's the difference between purpura and petechiae? Okay, purpura is just excessive bruising, okay? Now, you know, sometimes I run into something, I get bruises here or there, but if all of a sudden you start having all these bruises, so those are more like bruising, this is more your little petechiae, okay? And so those are just due to coagulation disorders and the fact that we are now not manufacturing our prothrombin or fibrinogen like we're supposed to, okay? So now you have to watch this patient for bleeding, okay? Some other things in men, because we have too much circulating estrogen and not enough testosterone, you're going to see the gynecomastia and the testicular atrophy are very common because they have more estrogen now circulating than they do the testosterone. So you're going to see some of those. Those are the most common ones that you see in these patients, okay, in the male patients. All right. Younger women, you're going to see amenorrhea, and older women, you're going to see vaginal bleeding. That's what they tend to see. Now, peripheral neuropathy happens because what happened, remember the most common cause is alcohol. And when you drink, what do you see them give alcoholic patients in the hospital? A banana bag, right? It's a yellow bag, and if you look at it, it's got B vitamins in it, okay? B vitamins are needed for normal nerve function, hence the peripheral neuropathy. And normal digestion. They will also, if they don't do a banana bag and they can take things early, you'll see them giving them vitamin B1, vitamin B6, you know, you got all these vitamins that all these B vitamins that you're giving them. So it's a deficiency of these vitamins that actually lead to the peripheral neuropathy that these patients have. Okay. So there's a little picture. He's cute, right? So this is just, again, putting together the later manifestations. I don't know, you guys should have this picture, right? Okay. So this is what you're doing when you study, say, why would this patient have jaundice? What's happening in the body? What are we going to do about it? We're going to talk about esophageal varices. They're very life-threatening. The patient can die. Why is ascites happening? Why does the liver enlarge? Why does the spleen enlarge? What is the importance of the spleen in the body? Hemorrhoids, edema, why is this happening? So that's what you need to do when you look at this. Why are these things happening, and what are we going to do about it? So some of these we'll talk about in a minute, like the veins on the belly wall. You see that more when you get the ascites, some of that kind of stuff. But that's what you should be thinking of. What's going on in the body? Why is this happening? And what are we going to do about it? All right. Labs, what can I say? Right? Diagnostic tests, right? What can I say? The abdominal ultrasound is usually done first, right? Because that's least invasive. But do these lab tests make sense? Yeah? Because, they're going to do serum electrolytes, because many times what you're going to find is if they're retaining volume, what's their sodium going to be? Okay, if they're retaining volume, it's low because of hemodilution, okay? Too much volume, okay? So if I have a cup, if I have 8 ounces of water with salt in it, and I have 20 ounces of water with the same amount of salt in it, right? It's going to be dilutional because I have a lot more volume and a lot more water. So you may have a low magnesium, you may have a low potassium, you may have a low phosphorus, etc. And some of those are related to malnutrition, and some of them are related to the fact that the kidney might not be working well because the kidney's part of this, right? And so we're going to start maybe having a few kind of renal or kidney problems also, okay? All right, here's where the fun starts. Complications of cirrhosis of the liver. This is actual, because I took the patient name off. This was in 2003, but this is an actual esophageal varices, blown up really big. Okay. Now, if that ruptures, what's going to happen?
If it's not banded.
Right. This one's banded. But what's going to happen? They're going to bleed, right? It can rupture, they can bleed to death. So varices are going to develop. They develop because of increased pressure within the portal system, okay? So what happens then, when you look at this little critter over here, is that when you have cirrhosis of the liver, when you have cirrhosis of the liver, what's going to happen is that you're going to get all these little nodules. So this is what your liver looks like with cirrhosis. Okay, I couldn't find anything else. I can't find a plastic one. If anybody walks around, finds a plastic one of these, get it for me. Okay, I've been looking forever because these will rot in a while. This one's already starting. I just got them. But this is what your liver looks like. What's your liver supposed to be? Smooth, right? It's supposed to be smooth. And now this is what your liver looks like. So think about the function of the liver when this is your liver right here. Okay, all these nodules are new liver cells trying to regenerate, but because I have scar tissue here and anywhere where it's smooth, those liver cells can't go anywhere because there's scar tissue. So they form the nodules, and then what happens is these nodules then impact the function of that liver, okay? So that's what's happening. The other thing that happens is that when you get those nodules, guess what those nodules can block? Portal blood flow, okay? Well, if it can't go up or forward, where does it have to go? Backwards. Look at where it goes. Look at where it goes, okay? They call this portal hypertension, okay? Portal hypertension because the pressure in this portal system is a lot higher now because the blood is not going through the liver up into the inferior vena cava, right? Okay? So they call this portal hypertension. So what happens then is that this backflows, okay? It can backflow into the esophagus, right? And cause varices. okay? It can backflow and cause varices, okay? The other thing that can happen is that it can backflow and then the person can have hemorrhoids, okay? Because this is all connected. So as this pressure increases, I can get hemorrhoids. I can get an enlarged spleen, right? So my spleen can get even bigger. So then what problem do I have even more? My anemia, my thrombocytopenia, right? All those things. So this gets even worse because it increases the rate at which it's destroying the RBCs, the WBCs, and the platelets, right? So increased destruction of my RBCs, my WBCs, and my platelets, okay, as the spleen gets enlarged. So now the spleen's getting mad, and so that's what happens. You can get hepatorenal syndrome, and what that is, and we'll talk about that in a minute, okay, is that eventually it's going to affect the blood flow to my kidneys, okay? And so these people are going to present with some signs and symptoms of decreased renal function. Okay? And then we already talked about the hemorrhoids. Ascites we'll talk about in a minute. All ascites is due to is the fact that I have decreased what? I have decreased albumin. Okay? When I have decreased albumin, what do? I third space. Okay? I third space. One of the places it likes to go is the peritoneal cavity. All right? The problem with it is as this fluid builds up into this peritoneal cavity, if I don't take it out, guess what it does? Guess what happens to fluid that sits, what happens to water that sits out on the ground for a long period of time? It gets funky and smelly, doesn't it? Well, guess what this can cause? Spontaneous bacterial peritonitis. Spontaneous bacterial peritonitis. Okay? To the fact where that belly can get rock hard. Okay? And we'll talk about each of these in a second. Okay? So anyway, that's some of the things that you're going to see just because I have a problem with this. So regardless, you've got to be very careful. You got to watch these people for lots of stuff, don't you? Okay, but the key is you got to watch for varices. You got to watch for that bleeding because that's life-threatening. And when I tell you they bleed. Believe me, they bleed a lot. So once the esophageal varices form over time, they can increase in size. If I don't relieve this pressure, okay, if I don't relieve this pressure in this collateral circulation, because that's what they call it, is collateral circulation, okay, because it's got to go a different pathway. That's all it means. That pressure in that esophagus, those blood vessels are really small in that esophagus, okay? Remember in the stomach, what did I say they call it in the stomach? Watermelon striping if they do an EGD. So watermelon striping. I'm not putting two P's in because I don't know how to spell that right, and I don't want you to get the wrong idea. I don't know if it's striping or stripping. I don't know. So I'm just putting one in there so it looks like a watermelon, okay? Let's just put it that way. I don't want you to get the bad idea. But esophageal varices are the most life-threatening complication of cirrhosis of the liver, okay? Because varices are going to deplete the intravascular volume, are they not? Because you're bleeding. When you bleed, it takes it from the vascular space and it's going out into my GI tract. Wow, just what I want is GI hemorrhage because guess what? It's a protein and now I can't break it down. And so what level goes up? My ammonia level. So then what happens up here, right? Is I start getting some neurological changes and problems because of that. Okay? So basically what's going to happen is eventually I'm going to lose so much volume, I'm going to become hypotensive and go into what's called hypovolemic shock. And all that means is a volume problem. My pipes aren't full. Okay, that's all it means. It's critical, it's life-threatening, but but it is a volume problem, and so you can go into hypovolemic shock. So we'll talk about how to treat that in a minute, okay? So we okay so far? We okay so far? Yeah? Okay, so I'll show you a nice picture. But you like mine better. Okay, so here's a nice picture, but mine's more memorable. All right. Quit laughing. She laughed at me. So here's a nicer picture. Okay, so I just see all these blood vessels here that come off the portal veins. You see all these? I can't draw. So here's the esophagus. Look at all the vessels you have in the esophagus. And so if these bleed, that's esophageal varices. See all the ones in the stomach? So you have all these blood vessels, and then you have coming off of here. See how it all goes to the GI tract? So everything's connected, your spleen, your stomach, your esophagus, right? And so this portal vein goes in here, and it goes into smaller and smaller vessels, and then goes out into the vena cava, okay? But I just wanted to show you how all these little blood vessels are connected. I can't do that on there. Okay, so there's all these little tributaries that come off the main vessels that connect all of this. Look at this circulation. See that? All over the place. And so that's why if this gets blocked, it backs up. And look how big these vessels are. Look how big these vessels are. Is it going to take much for these to distend, much pressure? Because they're smaller, aren't they? So it's not going to take as much pressure for them to distend, and hence we get the varices, and we can have problems, okay? We okay with that? All right, so basically what's happening here is blood is supposed to follow this pathway. Then all of a sudden I have all this scarring in here, right? So all the blood vessels in here, because this breaks down into smaller blood vessels in here, they're blocked. So it can't go that way anymore. So what happens is it has to go and find another place, okay? So it goes to the intestinal tract, the spleen, the esophagus, the stomach. Does that make sense? Okay, so here's my cirrhotic liver. This is how I want it to flow, and then it goes into the vena cava, right? But because I have cirrhosis and scarring, this is now shrinking. So even if scar tissue forms there, it can narrow this, can't it? Okay, or I can have one of those nodules there, or somewhere in the liver itself. So instead of it going forward, now it goes backwards. Okay, and that's what they talk about when they talk about lateral circulation. Okay, so esophageal varices is a huge problem. Okay, and it is a very life-threatening problem. And so my goal is to prevent them from bleeding, because if they rupture, good luck. Okay, good luck. Because you're going to have a hard time saving this patient if they rupture. All right, very hard time saving the patient. So basically, if you notice, I have collateral circulation because that blood is not flowing freely through the liver into the vena cava out into the body. Okay, so it's like, have you ever had a septic tank back up? Right? Where does it go? Comes up your bathroom, right, or wherever, because that's the collateral. That's normally it goes down those pipes and out to a septic field. So if you have a septic field, not sanitary sewer, but if you have a septic field, when that septic field gets full and that tank, you have a holding tank, some people have holding tanks, and you don't empty that out, then it has to go backwards, and what do you start seeing it come up right into your showers and things like that. So that's kind of what's happening. It's like a septic field is blocked. My main goal is to prevent and stop bleeding. That's my main goal, okay? And there's different ways that we can do that, because this doesn't tolerate, especially the esophagus. Remember how small those blood vessels were? They don't tolerate high amounts of pressure because they're not big enough, right? They're not big enough to tolerate high amounts of pressure, and so what they end up doing is they form like, they start to blow up, right? So it's like blowing up a balloon. All these little small blood vessels start blowing up. And the key is you can only blow them up, right, so far, and then what happens? They rupture, okay? So that's what you have to worry about when you talk about esophageal varices, okay? So you want to avoid anything that causes bleeding, correct? Makes sense? I don't want to give them anything that causes bleeding. And you want to do an EGD to screen for varices, okay? 80% of the varices that they find are esophageal, and 20% are GI. So the esophagus is the worst that you're going to see, okay? So the main goal is to try to stop bleeding. Well, how do we stop bleeding? Well, we, believe it or not, are back to our good old beta blockers, okay? How are beta blockers going, how do they stop bleeding? What are they going to do? Why would we even use a beta blocker? Okay, so I'm decreasing the pressure within that portal system, am I not? And if I decrease the pressure within that portal system, hopefully I'm decreasing bleeding. So the goal with beta blockers actually is to get the heart rate, according to evidence-based practice, around 55, okay? And then that will decrease the pressure within that system and hopefully prevent the bleeding, okay? Now, the literature also says that these are best used to prevent the first episode of bleeding, okay? The first episode of bleeding in patients with varices, okay? So we want to get them on these right away because they tend to work best for patients who have not bled yet, okay? And so we want to get them on as soon as we can. The literature says once they've already ruptured and bled and we've saved them, they don't have the same effect for the future times, okay? All right. So we need to stabilize this patient, correct, and manage the airway. So why am I worried about the airway in this patient? The varices and bleeding, right? Bleeding and aspiration, okay? So one of the things we're going to do is IVs. Now, what do you need to be cautious about with IVs? Who just don't increase. You gotta. It's a very fine line, isn't it? Because if I increase the blood pressure too much, what am I increasing in this system over here? Portal pressure. So am I doing any good? No. So remember, like he says, if the bag's full, why are you adding more volume? So you do not want to overhydrate these patients. So it's a fine volume. So you want to give IV fluids, but you want to be cautious that you don't overhydrate, okay? Because if I overhydrate, then I'm increasing the pressure. And if I'm increasing the pressure, then what am I doing? I'm increasing the risk of bleeding in these patients. And I don't want to increase the risk of bleeding in these patients, okay? So IV therapy may not just be IV fluids, it may also be blood products, right? So I may need to give them some packed RBCs, correct? If their blood counts are low, to restore blood volume, okay? So we're also talking about blood products, okay? What's fresh frozen plasma for? What does that restore? Okay.
The volume booster and the vascular system, you have to give it with 3 units of that.
Yeah, what else do we use it for? Okay, there you go. That's what I wanted to hear. So basically what it does is it replaces your clotting factors and it will decrease that INR, okay? So fresh frozen plasma, FFP, okay, is trying to replace clotting factors, right? Now how many have given FFP and didn't know that? Don't raise your hand, I don't want to know. Do it behind my back, okay? All right? Know what it's for. All right, vitamin K, obviously you understand vitamin K, right? That's your prothrombin. We don't have prothrombin, right? So we want to replace that prothrombin, okay? Now we have other medications to try to stop the bleeding, okay? So we have octreotide, okay? Octreotide or sandostatin is a vasodilator, right? And if I vasodilate, what am I doing? I'm decreasing pressure, right? Does that make sense? So concepts. So it's given as an infusion, and what we're trying to do is decrease that portal pressure, okay? So if I decrease pressure, then hopefully I decrease bleeding, correct? The other one is vasopressin or pitressin. That's a vasoconstrictor. How you can remember is because you're pressing, all right? You're pressing. So it's also used to raise blood pressure, but why would this be used? Okay, basically it does not cause total constriction. okay? It doesn't cause total constriction. When you think vasoconstrictor, everybody's thinking this. Well, then your hands and feet are going to fall off, okay? Which when you see people on 4 or 5 pressors in the unit, you got to check distal circulation because those pressures are going to clamp down on those vessels and decrease blood flow. So all this is doing is just making it just a little bit narrower, okay? Especially in the esophagus. So it's really working in the distal esophagus and the gastric veins more than anywhere. And so it's trying to constrict those to reduce blood flow into those areas. So if I can constrict the esophageal veins and the gastric veins, then I can prevent that blood from backing up into there, hence hoping to reduce esophageal bleeding. Now you have to be very careful with pressors in people that have coronary artery problems. Actually, the literature says do not give them in people with coronary artery disease because what is it decreasing? It's causing vasoconstriction, right? Which could cause me to potentially have cardiac ischemia and or an MI, okay? So you have to watch because it decreases coronary blood flow, vasopressors. And when they decrease coronary blood flow, then I have to be concerned about cardiac problems, okay? So basically, those are some of the things that we're going to do for these patients. Now, some institutions automatically give nitroglycerin if they're giving vasopressin. Okay, if they have to do it, they give nitroglycerin because nitroglycerin will vasodilate those coronary arteries, right? And hopefully keep the myocardium perfused, okay? So that's protocol in some agencies. So what are you as a nurse going to do for this patient with esophageal varices? What do you think their blood pressure would be like? Okay, we're losing volume. Okay, I'm going to have a decreased blood pressure, increase in my heart rate. Okay, increase in my heart rate. What do you think my H&H will be? Okay, what about my PTINR? High, right? What about my liver function tests? Elevated, right? Like we talked about this morning. So I'm going to go probably do an EGD on this patient, correct? And the other thing we're going to talk about in a few minutes is a balloon tamponade, which is seldom used anymore because of the issues with blocking airway. But what else are you going to assess in this person? What are we're going to do vital signs. What are some other things you've got to think about in somebody that has, you know, varices and liver function that you got to think about as nursing interventions?
Jugular veins.
Okay, maybe some JVD. Okay, level of consciousness, more especially when we get to the ammonia part. Okay. Would you avoid injections? Just basic stuff. Basic stuff. They're prone to bleeding. So no straight razors, you know, no whatever bristle toothbrushes. I don't know. Are they hard? What? I don't know. I only use soft. I don't know what the other names even are anymore. Protect them from trauma, monitor their vital signs, all that good stuff, right? That you want to do in these patients. So what do they do for these patients? Well, there's a couple of things that they can do for these patients. One of the things that they do for these patients is called endoscopic scope, obviously down into the esophagus. And this is the needle. And what they do is they find the varices and then they inject the substance into the varices. The inflammation then causes that varices to clot so that it can't rupture. Okay. So that's what sclerotherapy is looking at doing. And I can't say these are 100% effective, so I can't tell you that, okay? I can't tell you what's going to work and what's not going to work for patients. Yeah, and so the other thing that they can do is something called banding. They call it, you know, endoscopic variceal ligation because we've got to have a fancy name for everything, right, versus banding. And basically they just take little O-bands or little rubber bands, okay, and they're going to put these little rubber bands around these varices, all right, and then what's going to happen is it's going to decrease blood flow to the area, and then the varices will just fall off. Yeah, or hemorrhoids. What do they do for hemorrhoids now? What do? They tie them off. That's exactly what they're doing here. And when you decrease blood flow to the area dies, it just falls off and then just gets digested through the normal process. They prefer this over sclerotherapy because it has less side effects, okay? And the patient doesn't know those bands are in there, and it doesn't cause them any discomfort, you know, but it's just another method to be able to try to take care of the varices. We don't have a lot of things to do for varices, people. There's not a lot out there, so we don't, right? So anyway, complications that we're going to talk about are aspiration, and we'll get to those. And here's your tissue ischemia and necrosis, and then we'll, okay? So if the air starts to come out of here, this tube can move up and go up here and block what? My trachea or my airway, okay? So it can block my trachea or my airway. So you need to monitor these people all the time, okay? You need to monitor these people all the time because of the possibility of an airway obstruction. If you know there's an airway obstruction, you are going to cut the balloon and you're going to pull it out and you're going to call rapid response. Because I can't leave it in there. I can't leave it in there because they're going to suffocate, right? So that's why they don't use these that much anymore. So you really need to monitor that placement and make sure that's in there. Now the beauty of it is, you know, they use this sponge right here, which is nice for the nose, okay? And then it's taped, so hopefully this doesn't migrate, but you know how things are. You know, these air comes out of all this stuff, just like Foley's. They leak around them. Well, come on. Is it in all the way? Did the balloon leak a little bit? Do you need more air in the balloon? You know, you got to find things out of what's causing it. So if this moves up, my trachea is up here and it's going to block my trachea, okay? So that's why they don't like to use these anymore. This is it's the last step before going in and trying to do surgery because there's too many issues with the airway. You've closed that gastric pipe with the balloon, but you've left the airway open, right? And so then what happens is that secretions can get in that windpipe, so they can aspirate those secretions, correct? So that's why you got to suction them often, and that's why aspiration is a problem, because as those secretions build up, they can go over into that trachea, right, and into my airway. So that's a problem, and then if this dislodges, it can actually cause an airway obstruction, and the patient isn't going to get any oxygen, so you need to cut that balloon and get it out of there and call rapid response, all right, because you got to get it out of there or they're going to die, right? Want that to happen. So anyway, scissors at the bedside for emergency use, okay? Because we don't all carry scissors around like years ago. We all had scissors in our pockets, you know, nursing scissors, because we didn't have kits that had all that stuff in it, so we had our own little scissors, you know, and that's how we did dressings and everything else. So, all right. Shunts. Shunts, again, are rescue therapy, okay? Shunts are rescue therapy also. This is not something that we're just going to do for the sake of doing it. So this is another rescue therapy. And when you talk about shunts, what they're thinking of, or the term they think about, is something called surgical decompression, okay? And so when you look at these, I'm just going to go to the next page because you have this right next to each other on your slides, right? I just want to go to this because it's easier to show you. So basically what the problem is they don't usually use these the first time they have a bleed. They tend to use these more the second time they have a bleed or they have some rebleeding. And so you have a couple different shunts that they use. The first one, just look at the word, portocaval shunt. So what do those words mean to you? What are they doing? Okay, they're taking the portal vein and they're putting it to the vena cava. And that's where the blood should go in the first place when it goes through the liver, right? So if I do that, am I decreasing all this collateral circulation down here? Absolutely, because where's the blood going to flow? The majority of the blood's going to go right into the vena cava. So all it's doing is decreasing the circulation, okay? So when you look over here, okay, I'm taking this off, okay, and I'm connecting it right to the vena cava that's next to it. It's bypassing. Yeah, but it's okay because I still have a hepatic artery, do I not? I still have a hepatic artery. So I'm getting oxygenated blood to the liver. I don't have a choice. Again, this is a rescue therapy. So these aren't done very, very often, but basically what it's doing is it's bypassing that portal vein and the blood is going into systemic circulation. But I still have a hepatic artery that is still giving me some blood flow to the liver, okay?
Patients ones that would have to be on like hepatic dialysis.
I don't know. That's a good question. Well, it has to be filtered, but I still have the hepatic artery bringing some stuff, you know, to these people. When we're to rescue therapy, where do you think they are in this whole process? Yeah, they're not, we're close to not being around, okay? So this is just and I'm going to tell you what, them doing these are probably extremely rare, okay? Because what would they do with the patient when they're at end-stage renal failure, hospice? They're not going to go in and try to do these procedures. So these are just potential things that they can do. But the problem is you can get stenosis and occlusion, okay, of the shunts, and that's a very common complication. It's very frequent complication. So what am I going to put this patient through this? And then I'm going to get stenosis or blockage anyway? So what good is it going to do? Okay, so it's just going to bypass the portal vein is just going to bypass the liver. So the volume from all that lower GI tract, all that blood that goes from the lower GI tract over there, normally goes there. All I've done is disconnect this right here, and now I'm hooking it to the vena cava. That's all I've done. And down here, I gotta do something with this spleen because the spleen's ticked off. My platelet counts are dropping, right? My hemoglobin is dropping. Everything is dropping, and it's getting worse and worse. So I got to get rid of. People get their spleens out all the time, don't they? But your bone marrow can still produce blood cells, right? So what they're doing then is because they don't want to have our counts to continue to drop. They're taking that splenic vein and they're connecting it to the renal vein. Okay, and so we actually had a patient. That we were taking care of last week that had a platelet count of 4. I've never seen that in 40 years, that low, 4. Right? Don't go looking at me like that. Yeah, I've never seen 4. That's unbelievable. Not knowing what's causing it, right? Trying to go back to the autoimmune theory. So we're right back to autoimmune. Interestingly enough, they didn't have any bleeding problems, which I was really surprised. Okay, but a platelet count of 4. So when I keep getting something like that, my hemoglobin's at 7, my platelets are at 4, my white blood count's in the toilet, what do you think I've got to do? One of the things I can do is say, okay, spleen, I know you're not happy and you're mad. And so because you're mad, you're increasing the breakdown of all these cells that I need in my body. So I got to get rid of you, right? I got to get rid of you. And so that's what sometimes happens. Okay. So again, these are rescue therapies. These are not routinely done. Okay. The other thing that they do, which is kind of interesting, is a TIPS procedure. Okay. And a TIPS procedure is a transjugular. Okay. So that ought to tell you something right there. Intrahepatic portal systemic shunt. So this is a shunt. This is done in interventional radiology. Okay, it's not actually, it's a surgical procedure, but it's not done like in the operating room. Okay, so basically, again, this may be used as a measure to decrease this portal venous hypertension. We actually had a student have a patient that was going to Ann Arbor to have this done a couple semesters ago. They were all excited. Oh, my patient's having a TIPS procedure. They're leaving to have a TIPS procedure. Well, yeah, it's exciting, but they're not having it here. So, you know, I mean, you're going to follow them down to Ann Arbor. So basically, it's used to control long-term ascites, okay? And it's used to control the variceal bleeding or the portal hypertension. It's done in interventional radiology, and all it is you put in a shunt or a stent between the systemic and the portal venous circulation. So they put a catheter in the jugular vein. Okay, so your jugular vein, everybody knows where that is, right? You've seen IJs and EJs, right, done on people. So they put a catheter. Let me show you here too. So actually what they're going to do is they're going to put a catheter in the jugular vein, and they thread it through the superior vena cava and inferior vena cava into the hepatic vein. So here it is. So they thread it through, so now the blood comes through here, and this is where the blockage was. So all they're doing is, it's like doing a cabbage, right, where you're bypassing the area of the blockage. And so they're putting this shunt in, so then the blood, see how the portal vein breaks off into smaller things when it gets in here? So it's gonna come in here, and it's gonna follow, right, go right through there and into the vena cava, okay? So they put those in interventional radiography. So it's going to reduce that portal pressure, right? Because it's going to allow the blood to flow like it's supposed to, correct? So through that shunt into the vena cava. So again, this carries the blood from all the lower part of the body through the portal vein. It will go through that shunt, okay, and go into the vena cava, right? And then into systemic circulation. So the goal is to divert the blood flow into that hepatic vein right here and out into the vena cava because there's a blockage somewhere in there preventing blood flow, okay? All right, so that's basically all that is, okay?
So with those rescue therapies, those are just bypassing stuff. So that's not, when you bypass them, we're not gonna get the functions of the liver, like removing the waste.
No, you're not going to be able to fix that. And sometimes you can't fix it at all. That's why they're just rescue therapies. They're just therapies to decrease that portal hypertension to try to prevent bleeding more than anything. Because esophageal varices is the major cause of death in these patients. And when they bleed, believe me, it's not pretty, okay? They bleed.
So when we do those procedures, we're looking for other therapies also, like your lactose and stuff that's gonna.
Yeah, we're gonna get to that. Yep. Yeah, we gotta think of other things on how we can manage. So that's why, like, you get rid of the spleen. You get rid of the spleen, right? And then hopefully I don't have as much destruction of the blood cells that I need in my body, right? For things to work, okay? So sometimes we gotta think about that, so. All right, so why don't you get up, stretch for about 5 minutes, and then we're going to start talking about portal hepatic encephalopathy. Now, when they get to this, this can occur actually in any condition in which the liver is damaged. So it doesn't always have to be cirrhosis of the liver. It can occur in any kind of situation in which the liver is damaged and it causes the ammonia to build up in the body and not be detoxified, okay? So it doesn't always have to be just cirrhosis of the liver. But the bottom line is that the liver can't convert the ammonia to urea to be excreted in the body. So what it does is it crosses that blood-brain barrier, and then the problem is neurological signs and symptoms, okay? So that's kind of what you're going to see in these patients, all right? So I don't want you to look at your notes. I want you to kind of not look at your notes for me for a minute. And I want everybody to take one of these little, so don't look at your notes, be honest, don't look at your notes. 1, 2, 3, 4, 5. And I'm going to pass these out, and what I want you to do is that when you think of portal systemic encephalopathy or hepatic encephalopathy, I just want you to write a word on here that comes to your mind when you think about that, okay? Just write a word down without looking at your notes that you may think about in this patient that has hepatic encephalopathy. Well, you could do more than one word, but you don't have a lot of room to write. Okay, so what I want you to write down just a word that comes to your mind. Some of us might have more trouble with that than others.
Looking right at me for that one.
Well, you're going like this and looking
I was
at
curious when you read these.
Yeah, I'll save you this one, okay, so you can take it.
No, you need that.
Oh, I need this one?
Blueprint or reminder.
Oh, it's a reminder from my old age, I can't remember, right? In case the teacher forgets. So just one word without looking at your notes. Then what I want you to do is I want you to take it and I want you to pass this head around and I want you to stick whatever you're thinking in that head. Wish you put whatever you're thinking. No, don't, you guys are terrible. Yeah.
Ooh, that's a good one.
Now, I am gonna read these, you know. Too late now. Too late now, girl. Too late now. You're putting all bad things down. We'll see where your minds are after you've carb loaded. Okay? Let's see where your mind is since you've carb loaded. I lose everything. Isn't that awful? Are we passing the head around? Don't read them right now. Oh, that'd have been a good thing.
I didn't understand the question.
Well, I was letting you, we'll see. But you're right.
Mine's gonna be the only one that probably.
This poor head. Oh, they just poked his eye out. Wow, Lauren. Wow. Get out your aggression here today. It's really aggressive. Yeah, I saw that. It's long. I don't see it down. Let's see what everybody has to say about our little cirrhotic liver patient. Now remember, when you have PSE, this is bad, okay? So this person's in bad shape when you get PSE. Kyle was talking about a patient that, you know, they need to have some discussions with that has liver issues, correct? They need to have some discussions on how far are we going with this patient. Is it time we start talking about hospice, or where are we going with it? Picture, but you know how a hummingbird's wings just go really fast? So it's a flapping tremor. Basically, when you ask the patient, so if you hold your arms stretched out like this, can everybody do that? The patient's unable to hold them in this position for very long. Look at her, she's already flipping, and I haven't even told her to, so she's assess her. So the patient's unable to hold this position, and so there's going to be rapid flexion and extension of the hands. So this is what they're going to do, hyperreflexia, okay? The asterixis, this is what's going to start happening because they can't hold them still because of irritation to the brain from the elevated ammonia. Feeder hepaticus is called the breath of the dead, okay? Oh, it's liver disease breath. And it is it's caused by the increased ammonia levels. It's caused by the inability of the liver to metabolize carbohydrates, proteins, and fats. And it's like oh my God, it's like a really musty, it's bad. It's really like a musty smell. I mean, you said you've smelled it before. I have too, but it's really a musty smell, or almost like a fecal odor kind of smell to the breath that they get, because the liver can't break down waste products and metabolize substances in the body. They get very violent. You do an EEG, and what do you think the EEG may start showing? Yeah, hyperactivity, maybe some seizure activity. They get comas, those kinds of things, okay? All right, so how do we treat this patient? Nobody even thought of treatment. Poor guy. Medications are used very sparingly. So when we get to this stage, we don't use a lot of medications because why? I just can't metabolize them, okay? So I'm not going to use a lot of medications because I can't metabolize those medications. So we've got to be very careful with those kinds of things, okay? So we want to decrease the amount of protein that we're giving them, because what's protein broken down into? Ammonia, right? Well, I already have a problem with ammonia, so I want to do a low protein. Some books say low to moderate protein. And again, the question was asked, how do you know how much? Well, I got to look at my patient, okay? I got to look at my patient. and the dietitian can figure out exactly how many, grams per whatever. But normally they say a low protein or decrease the protein in the body. Okay, and then of course, if I'm not using protein, I got to give them some carbohydrates and some calories, don't I? So if I'm not using protein, I have to use carbohydrates and calories. And again, I don't want a lot of fat because the liver can't metabolize it. Okay, so we've got to be very careful. We already talked about the meals. Neomycin sulfate. Neomycin actually kills the bacteria in the gut. Years ago, this is how medicine has changed. Anytime years ago when I first graduated, and for quite a few years afterwards, when anybody went for bowel surgery, we prepped them with neomycin, okay? Because we wanted to kill the bacteria in the gut to decrease the chances of that patient getting an infection post-surgery. So we always gave them neomycin. Well, now we're giving them neomycin to kill the bacteria in the gut. Why? Because ammonia is made because of the action of bacteria in the intestines, right? On the protein. So that we got to get rid of the bacteria, then we decrease the ammonia. So they use neomycin sulfate. The problem is it can kill the kidneys and cause me to have a hearing loss, so that's not really good. So it sterilizes the intestine to decrease the intestinal flora in the colon, hence decreasing the ammonia level, and that's what I want to do, okay? I want to decrease that protein breakdown, and I want to decrease that ammonia production. So that's why we give them neomycin sulfate. Now, sometimes they use Flagyl, okay, because it's less toxic than neomycin sulfate, and it has a similar action, so it doesn't have as much of an impact on the kidney, but I've seen the neomycin used most often, okay? Cathartics and enemas. Why would I even think about cathartics and enemas? Yeah, there's ammonia in the stool. And so if I give them an enema or a cathartic and I can clean out that bowel, then I'm getting rid of the ammonia that's sitting in that stool that can be absorbed, right, into the body. All right. Lactulose. What about lactulose? Everybody's heard about lactulose. What's lactulose do? Okay, it traps the ammonia in the GI tract or the gut, and it prevents it from being absorbed, so we expel it from the colon. Now, one of the things that you need to understand, the goal is not diarrhea. Then you're giving them too much. All right? The goal is to have, according to evidence-based practice, 2 to 3 stools a day, not to have diarrhea. So the goal is 2 to 3 soft stools a day, not diarrhea. And the other goal is to give them enough so that everybody said they were crazy, right? Mental status, so that I decrease the amount of confusion the patient is having. So everybody thinks the goal is diarrhea, and that's not the goal, okay? That's not the goal. I don't need to give them diarrhea in order to decrease that. The patient may complain when you give them this of some like bloating or cramping in the intestinal tract. And if I give them the lactulose, I want to know, what is my ammonia level doing, right? Is it working or isn't it working? That's the key. Okay, is the ammonia level going down? Is it not going down? Okay, and the thing too is that you can lose potassium in your stool also. So if you have diarrhea, then I have to worry about hypokalemia in these patients. So you have to think about that also. Okay, and control bleeding, right? We already know that, right? We good with that? Nursing intervention, some of the things you need to think about, and somebody mentioned it on here, is safety. So somebody got safety with this little guy's head. So you have to think about safety is something. The meds we already talked about, the low protein diet. And I always think about skin integrity on these patients. Okay. So those are some of the things that you need to think about on patients. So this is just the nice way to put it together. You know, these people don't have a life, so they have plenty of time to draw pretty pictures that I can't draw. Okay. So again, this is just showing you blood ammonia, okay? And this is just showing you some of the things that are going on. These are the causes, and then he's confused, where am I? Okay, where am I? So I gotta decrease the ammonia level, right? So I gotta decrease his little ammonia level. See, and then we've got stuporous, right? Stuporous, we can even go to coma. Okay?
If their albumin was also low,
Yes.
you wouldn't want to give them IV albumin if they can't have protein, right? In this case, what do you?
Well, the IV albumin is usually reserved for them because of the ascites that we're going to talk about. That's when we tend to reserve the albumin. And we have to give it, or we can't control the ascites.
Unless we keep giving the paracetamol.
Right, but they give it with the paracentesis, is what they do, the albumin. Because if I take the fluid off, and I don't bring up their albumin level, I'm going to fill right up. The next day, I'm going to remove another 8 liters off my belly. So they either give it during the paracentesis procedure or right when they get back from a paracentesis. So, and you know what? It's IV, so it's not going to stay in there. I'm going to get rid of it. Okay, so I'm going to get rid of it. Well, here's your ascites. Look at that belly. Okay, it's mine after I eat too much. Looks like that, and I do have a little bit of an issue some days with that. So basically, this is a belly with ascites, okay? And so basically, it's an accumulation of fluid in that peritoneal cavity. And portal hypertension tends to be the main cause of ascites, okay? Because if I have increased pressure, then fluid backs up into this GI tract and into the peritoneal cavity. But other reasons are the decreased proteins and the increase in aldosterone, okay? So basically, why would I have how does aldosterone fit into this picture? Yeah, exactly. Your kidneys are trying to help a little bit, right? And so what's happening then is you are getting an increase in those aldosterone levels, and because where's the fluid? It's in my belly, it's not in my pipe. So the kidneys say, hey, guess what? I'm going to help you out. And so I'm going to kick in that angiotensin renin aldosterone system. And what's going to happen then is that I'm going to have even more water retention, which is going to contribute even more to my ascites, which is going to contribute even more to all the edema that I'm having. Okay, so that's what's happening. And the other thing is the aldosterone is not being metabolized by the liver. All right, so it's going to be high. The aldosterone levels are going to be high because it's not being metabolized by the liver. So look at that belly and look at the veins. Look at the distended veins. The engorgement. Now, I would never lay this person flat because they're never going to be able to breathe. Okay?
When did you want your beef for?
Well, I'm getting it. Thank you. I'm glad you reminded me. So, thank you. So, this is my acidic belly, okay? So this is my acidic belly right here. Thank you for reminding me. So when I look at the belly, okay, a couple of things I want to show you first. Am I going to gain weight because I have all this fluid that I'm retaining? Absolutely. Look at this belly. This belly gets so big, they get those striae or stretch marks on this belly. So these are my little stretch marks right here. They go the wrong way. Here, put them this way. No, I want them this way. Get them all different ways, don't we, ladies? Okay? The distended abdominal veins that you saw in the previous picture, right? Dehydration, because where's my fluid? Right here in this balloon, right? It's not in the pipe. So I'm always going to say, well, I'm thirsty. My mouth is really dry. Those kinds of things. Decreased urinary output because I have decreased perfusion to my kidneys because where's my volume? It's right here in my great big belly, right? It's not where it belongs. So I have decreased urinary output. Now, why would I have hypokalemia if I have decreased urinary output? What am I giving them? Diuretics, okay? So I put it on there because I wanted you to think about it. So my biggest problem is respiratory. So usually the hypokalemia is diuretic induced. So what's going to happen is this patient's going to go down for a paracentesis, okay? So the goal, especially when they start having respiratory compromise, right? If I start having respiratory compromise, right, I'm going to have a paracentesis. When I have a paracentesis, what's going to happen to my belly? Okay, right? This is what I want to happen to my belly when I have a paracentesis. You can remove liters. liters. But you gotta be very cautious because the body still knows this is fluid in there, so I don't want him to go into hypovolemic shock. So now I'm removing this fluid from this belly, this big belly, and if I don't give them some albumin, hence the albumin is on there, what's gonna happen? It's just gonna fill right back up. Because if my albumin is low, I'm gonna continue to third space, am I not? So I'm doing my paracentesis, and either during or right after, I have to give them some IV albumin. Now, can't remember the half-life of IV albumin, but you know what? If this is a chronic problem, what's gonna happen anyway? I'm gonna fill back up, okay? So this may or may not work for me, all right? So that's what I'm doing right now is I do a paracentesis, they go in there, they tap it, right? And they remove the fluid, okay? So that's one of the things they can do. I am not gonna talk about sodium and fluid restrictions, okay? Now, why do we use aldactone or spironolactone? Potassium sparing. Well, why would I want potassium sparing? Okay, because I'm pulling fluid out, plus I'm giving them some diuretics, right? And with diuretics, what do I lose? My potassium, right? And so I want to make sure that we maintain a normal potassium level. Now remember, the goal of this paracentesis is because I'm having respiratory compromise, okay? It's not necessarily just to remove the fluid. My concern is, if I don't get it all out and this fluid sits in here, I can end up with, this is a spontaneous, right, bacterial peritonitis. All right, that's a complication of this fluid sitting here in my belly. So that's another reason I got to get it out of there, because the patient can go septic if I don't get it out of there, okay? Because those bacteria then can get into the bloodstream and I can become septic, all right? Oh, sorry. So we usually give albumin, all right, during or after the procedure. Sodium restrictions, as I said, as low as 500 milligrams a day, depending on what's going on with the patient. So very low sodium, fluid restrictions. Now, if they have a normal sodium level, I don't have to restrict it, right? It's only when the sodium is too high. Then you really need to watch salt substitutes, because what do salt substitutes contain? Lots of potassium. And no table salt. Try it. If you ever bought it by accident, people move things on the shelves. Oh, I see carrots, and you buy carrots, you get them home, you're like, what is wrong with these? They taste horrible. I did that one time. I thought, I checked the date on the bottom of the can. I said, there's something wrong with these. These just taste terrible. I couldn't figure out what was wrong with them. I didn't eat them because I couldn't stand them. But when I looked at the can later on, it was no salt added. Try them. Try them. And the reason why, what do we tell our patients? And then they don't eat. We're like, well, you got to eat. Try it. You wouldn't eat it either. You'd be sticking that salt shaker under your mattress in the hospital too, to be able to eat that food. Just try it. Try it once. 50 cents when they're on sale. Get a can of no salt veggies and see what they taste like. No salt green beans or carrots or something. It's absolutely horrible. Okay? All right, so that's basically why I want to do this. When they do a paracentesis, sometimes they will just take a sample of the fluid and send it to lab to make sure there's nothing growing in there. Okay, so they can get on top of it so that we don't have this spontaneous bacterial peritonitis starting on my patients. Okay, does that make sense? Yeah, and we have to watch, remember, when we take these fluids out, because rapid removal of the fluids can cause their blood pressure to drop and them to go into shock, because even though it's not in my pipes, the body still knows it's fluid that's there. So I can still become hypovolemic. So when these patients come back, you need to monitor their vital signs, okay? Collaborative management, this is not done again very often. There's a lot of these things that we don't really do much, but this is called a Levine shunt, and basically it provides for that fluid to continuously go back into the venous system where it belongs. Okay, so the fluid is going back into the venous system. So I'm just going to the picture because it's easier for me to show you the picture. Okay, so you see how this has lots of little holes in it, just like a Foley catheter. It doesn't have that many. This is a one-way valve. okay? And then it goes up here either into like the subclavian or the jugular. And what happens is when the pressure is greater in here than it is here, this valve will open and it will allow fluids to go into the venous system, okay? So the whole purpose is instead of having to do a paracentesis all the time and tap them, this is a shunt, so to speak, which puts that fluid back into that venous system. So it has a pressure sensitive one-way valve right here so that I don't have fluid coming back in, and it allows that acidic fluid to flow from the belly up into the vena cava and into systemic circulation, okay? Because otherwise I'm tapping these people. The problem is I have now a new opening, so I can get an infection. The other thing is, though, these things can plug. And so what good does it do if they plug? It's rarely used now because of the complications that the patient can have. So this isn't done that often anymore, but it's just something that's out there, okay? All right, ascites, right? Anything related to fluid volume. The best way to be objective in measuring that abdominal girth, right? Best objective measurement. The problem is you got to place the tape measure in the same spot. So we used to put little marks on the tummy, so we knew that's where it was going. So basically that's the best thing to do, is to measure abdominal girth. I think the rest of it you understand, right? And I don't have everything on here, but spontaneous peritonitis, as I said, is due to the fact that there's fluid still sitting in here, and it gets stagnant when it sits in here, doesn't it? And it just sits there. And so bacteria can form, and hence I can start having some problems. So you need to assess your patient, because what's going to happen is their belly is going to get rock hard. They call it rigid abdomen, or a board-like abdomen is the terminology that they use. So basically you want to listen for vowel sounds. You want to palpate the belly, right, to check for, the abdomen being firm. As I said, when they do a paracentesis, they're going to send some of the fluid down to the lab, and they're going to check for something like that, okay? Hepatopulmonary syndrome is, guess what? I have too much fluid here in my belly and I can't breathe. That's the bottom line. That's why we use a paracentesis. It's basically reserved for people because they have respiratory problems. So I start having dyspnea because I have so much pressure in my belly that when I go to take a deep breath, my diaphragm and lungs can't expand. And so I'm not getting oxygenated very well. So I need to monitor these patients' oxygen saturation levels and, things like that, so that I can check for hepatopulmonary syndrome, okay? The kidneys may not be perfused because, remember, what are they doing? They're vasoconstricting to try to, say, hey, your pipes aren't full. And you're saying, well, my belly's full. The kidneys are saying, well, I don't know your belly's full. I want to fill your pipes. And so, of course, now we're, vasoconstricting, and then aldosterone comes into the picture, and then renal failure follows, okay? If they get hepatorenal syndrome, that has a very poor prognosis, okay? So we're to the point where this indicates a very poor prognosis with a patient that has cirrhosis of the liver. So this patient, this is probably somebody you need to think about having some dialysis, some hospice, okay? Liver dialysis is out there. This is indicated when the patient has hepatic encephalopathy. They will do liver dialysis, and they use this for a severe drug overdose. That's usually when they do this. So what this does, and again, I've never seen this, and there is a video you can look at, because if you notice it came from a video, and you can push play and it will explain it better. I don't care how they set it up. That's not important to me. What I care about is my patient improving because of this, right? That's what we look at as a nurse. So basically, it's removing the toxins from the body to try to prevent the patient, from going into further organ failure. The other, a liver transplant. Liver transplants do work. Very long procedure, multiple doctors, right? They have teams of doctors that switch because it's so exhausting. About 80, the literature says about 80% of transplanted livers are still working a year later, okay? But what do you got to think about when you do transplants? Okay, you got to give them something, right? Medicines that cause what? Immunocompromised, yeah. So you got to give them medicines because we don't want to reject the organ, do we? Okay. So nursing assessment, I don't have everything on here. I just can't possibly do it. When you think about the patient with cirrhosis, the best thing that I can tell you to do is take a worksheet and say, do I understand a patient with cirrhosis? Do a head-to-toe assessment. What would I find in this patient? Somebody's already done that, which is good. I think that kind of lets you know, do I understand? Can you apply the information that you had if you can fill out a worksheet, okay? Nursing interventions, again, I'm not going through all of these. I think we've talked a lot about most of these already in some fashion, but these are some of the things that you need to look at. And then again, as far as teaching, all I can tell you is they're at in the process, okay? If Sherry's patient had that fifth, they need to talk about, do you understand how alcohol affects the liver? They couldn't with their blood alcohol level as high as it was. You could have talked till you were blue in the face. You got to be really careful. Tell people to be really careful with over-the-counter meds. Tylenol is hepatotoxic. The most you can give is 4,000 milligrams in a 24-hour period of time. But if I have liver disease, that's probably too much. But people take a lot of over-the-counter medicines. And when you ask people, what medications are you on? They're going to give you the ones that are prescription. You have to specifically say, now, are you on any over-the-counter medications, or are you on any herbal medications, etc., or else you're not going to get the answer that you want to have, okay? So that's just kind of some of the things you need to think about, okay?